honorable dignitaries, respected teachers, and my colleagues, a very good morning to one and all. Well, Paul Kalnithi said in her book, When Breath Becomes Air, that human knowledge is never contained in one person. It grows from the relationships we create between each other and the world, and still it is never complete. So let's just impart and share our knowledge with each other. Ask questions, share your views, experiences, and enlighten us with your wisdom. With this, I, Dr. Shubhra Srivastav, feel privileged to welcome you all on behalf of Department of Pulmonary and Critical Care Medicine for COPD Update 2023 on this World COPD Day, which is celebrated on 15th of November. Chronic obstructive pulmonary disease is the third leading cause of death worldwide, causing 3.23 billion deaths in 2019 and seventh leading cause of poor health worldwide. Tobacco smoking accounts for over 70% of COPD cases in high-income countries. In low to medium-income countries, tobacco smoking accounts for 30 to 40% of COPD cases, and household air pollution is a major risk factor. World COPD Day is an annual global initiative run by Global Initiative for COPD, who is a member of Forum of International Respiratory Societies. The goal of World COPD Day is to raise awareness and present new knowledge and novel therapeutic strategies for COPD worldwide. The 22nd Annual World COPD Day will take place on November 15, 2023. This year's theme, Breathing is Life, Act Earlier, aims to highlight the importance of early lung health, early diagnosis, and early interventions. Keeping lungs healthy is an integral part of future health and well-being. It is now more important than ever to act sooner. On this occasion of COPD Update 2023, we will be having some presentations by distinguished professors, followed by inauguration and lunch. Post-lunch, we will be continuing with the rest of the presentations. We bid a warm welcome to all the renowned speakers and chairpersons who took out their valuable time and joined us today to be a part of this update. We are honored to have you all with us. Now, I would like to invite Professor Ved Prakash Sir, Head of Pulmonary and Critical Care Medicine, to come on the stage and welcome our delegates. Sir.
Thank you, Dr. Sobra. At the outset, on the occasion of World COPD Day, that was on 15th of November, I welcome you all in the COPD update this year, which is being organized today because of festive season. We have announced for 17th, and in this program we will host the faculties from Lucknow itself and from Delhi also, and I welcome all the faculty, all the dignitaries, all the delegates, residents, and staff to this very important event. As you all know, the COPD is going to be the third killer worldwide up to 2030. So it is like epidemic. Many has stated like epidemic of COPD. We are approaching towards, and you all know that we cannot treat, even we cannot cure this COPD. We can control the symptoms and control the disease process and the progression. So we have to work for the preventive strategies, and being the major risk factors like air pollution, which is a global issue. We are observing our major cities in the red zone going high and worsening the breath of common individual. Apart from that, which is our own intoxication, I can say, that is like tobacco smoking and other form of tobacco chewing, and the बायोमास फ्यूल एक्सपोजर, जो हमारे गांव में हमारी माताएं बहनाएं जो चूल्हे पे खाना बना रही हैं, वो कंडे का, उपले का, बायोमास का, कोयले का उपयोग कर रहे हैं। ड्वेलिंग्स छोटी हैं, वेंटिलेशन नहीं है, और कई एस्टिमेट्स हैं कि कुछ लोग कहते हैं कि 5 से 10 सिगरेट के बराबर होता है, कुछ लोग कहते हैं 20 सिगरेट के बराबर उनका एक्सपोजर हो जाता है एक बार खाना बनाने में, दिन भर में। तो ये जो इश्यूज हैं, इनको एड्रेस करना और इस अवेयरनेस को गांव-गांव तक, जन-जन तक पहुंचाना, जिससे कि सब लोग प्रिवेंशन की तरफ भी बढ़ें और सरकार भी जो सुविधाएं दे रही है, जो सब्सिडी दे रही है, उनको और एक्सटेंड किया जाए एक कॉमन मैन तक, जो कि एक अंतिम पंक्ति के लोग हैं, उन तक इसको पहुंचाएं, क्योंकि कोई क्योर नहीं है। और जैसा कहा एक्सपर्ट्स ने कि अंत में लंग ट्रांसप्लांटेशन, वहाँ तक स्थिति आती है, जो कि बहुत ही कॉस्टली अफेयर भी है और बहुत ऐसी जो क्वालिटी ऑफ लाइफ है जिसको हम लोग अवेयर कर सकते हैं, प्रिवेंशन के द्वारा जिसे हम रोक सकते हैं, ऐसी क्वालिटी ऑफ लाइफ की हम लोग जो उम्मीद करते हैं आफ्टर लंग ट्रांसप्लांटेशन, तो बहुत ही डिफिकल्ट है। तो आज हमारे बीच में प्रोफेसर राजेंद्र प्रसाद सर, जो कि टीचर ऑफ टीचर्स हैं, हमारे गुरु हैं सभी के, और इस प्रोग्राम के चेयरपर्सन हैं। मैं आपका स्वागत करता हूं सर। हमारे बीच में बीपी सिंह सर, जो मिडलैंड हॉस्पिटल्स के डायरेक्टर हैं, वो अभी पहला टॉक हम लोगों ने रिक्वेस्ट की है। सर ने कहा कि सर ही इसको एक तरह से ओपनिंग करें, तो वी आर लकी इनफ टू हैव प्रोफेसर प्रसाद सर एंड डॉक्टर बीपी सिंह सर विद अस, एंड वी हैव डॉक्टर भास्कर, रवि, डॉक्टर राकेश, डॉक्टर श्रीवास्तव with us. So we are now starting the program. So I welcome once again to this important event. Thank you.
Thank you, sir. Now, I would like to invite chairpersons for our first session. Dr. Rakesh Chaudhary, sir, Director and Senior Consultant, Pulmonary Medicine, Sahaj Hospital, Lucknow. Dr. Rahul Srivastav, sir, Professor, Respiratory Medicine, Integral University. Dr. Ravi Bhaskar, sir, Professor and Head of Department of Pulmonary Medicine, Career Institute of Medical Sciences. Welcome, sir.
Good morning to all of you. Thank you, Dr. Prakash sir, for inviting all us here for an academic program on update of COPD. In first speaker, Dr. BP Singh sir, as we all know, is the senior most chest specialist, international pulmonologist of Lucknow, and he is our teacher too. So I would like to invite Dr. BP Singh sir to speak and enlighten us on COPD.
Thank you, Dr. Rakesh, for the kind introduction. And good morning to all of you. Good morning, sir. Professor Rajendra Prasad. I'm really thankful to Dr. Ved Prakash for giving me this opportunity to share these moments with you in this morning. And I will just go through this very important topic. Actually, we all have been using monoclonal antibody in the management of severe bronchial asthma. where you, in spite of the standard of care, you are not able to control the symptoms and patients do have recurrent exacerbation. But there is a new emergence of concept of use of biologicals in the management of the COPD. It is still evolving. Few trials has come up. I will just enumerate few of them. Only thing is that yes, this biologicals is a right in the management of the COPD, but it still is too early, and still the data is just pouring in, and we will just analyze this data, how it can be used in our clinical practice in the management of the COPD, especially those who are having the recurrent exacerbations. So, as you know, the COPD causes the debilitating symptoms, and it developed due to the complex involvement of, and basically the different interactions of the host and its environment, including the genetic susceptibility, exposure to the tobacco smoke, and the chronic airway inflammation. That is what the most important thing is. The inhaled pollutants, microbial pathogens and allergens bind with the pattern recognition receptors on the bronchial epithelium and promote a cascade of events that trigger both immune and inflammatory changes into the airway. And that leads to the various aspects of the inflammation. The cytokines known as alarmins, such as the thymic stromal lymphopoietin, interleukin 33, and interleukin 25, IL-25, are released from the bronchial epithelial cells and can trigger the Th2 and also non-Th2 immune pathway. And you all know that in the asthma, it is the Th2 pathway which is the most important and relevant. But in the COPD, it is the Th1 pathway which is predominantly important. But later on, a few studies have shown even the 20 to 40% of the patients with COPD, they can have this type of pathway involvement with the Th2 also. The inflammation often persists even after removing the triggering factor. So once the cascade of the inflammation starts, it continues. And due to the altered immune responses and alteration to the microbiome. So you must understand, basically once you stop the trigger, in spite of that, the inflammation, once it sets in, it continues. And this chronic inflammatory change and repetitive injury from the tobacco smoke and other exposures can create a cascade of events, including airway remodeling that results in fixed airflow obstruction and significant respiratory morbidity and mortality. The tobacco smoke, as you all know, is a common, as already been mentioned by Dr. Shubhra in his initial address. Basically, in 70% of the patients with the COPD, it is the causative thing. And it is best characterized basically as an inflammatory trigger in the patient with COPD. But microbes can also contribute to the disease development and further cause acute exacerbation, as also it is there with pollens. The typical sputum samples of the COPD patients exposed to the air pollution contain higher neutrophil and lymphocyte counts, but not necessarily higher eosinophil counts, as already mentioned. So in COPD, you will have predominantly the neutrophilic cells, and at times you can have the lymphocytic cells, but occasionally, like as already mentioned, that around 20% to 40% patients you will have eosinophils also. While a lot of has been learned in the last few decades about the inflammatory immune pathways implicated in the acute COPD exacerbation and the disease progression. The primary anti-inflammatory medication in use has remained oral corticosteroid for the treatment of acute exacerbations and inhaled corticosteroids for the maintenance therapy in patients that are having the frequent exacerbation. So that is the reason why you are using the triple drug therapy in the management of the COPD, where the recurrent exacerbation has been a complicating factor. The potential side effects of the long-term oral corticosteroids are very well known. I don't think that it needs to be elaborated. However, the corticosteroids are not particularly effective in suppressing the neutrophilic inflammation. That is an important thing. Other anti-inflammatory agents used for COPD have included the phosphodiesterase inhibitors and macrolide antibodies, and both of which have been shown to reduce the neutrophilic inflammation and reduce the exacerbation frequency. So this is basically one of the other things that we have been using, the macrolides and also the phosphodiesterase inhibitors in this context. These basically the steroids have been considered the immunosuppressive drugs in that they are having small molecule therapeutics with effects on several intracellular pathways and raise concerns about the increasing risk of infection and or the dysbiosis which is used. The immune modulator drugs, such as the biological therapeutics, target specific immune pathways and have specific effect on the particular pathway or cell type, and consequently they tend to have fewer deleterious effects because they have a very focused approach on the target. Immune targeting the COPD was focused on targeting and neutralizing the cytokines and chemokines. And another is the targeting proteases such as modulating metalloproteinase. So these are the two mechanisms basically involved in targeting the COPD. The clustering of the disease has been predominant by a neutrophilic or the eosinophilic disease, has been one of the most simplistic manner to classify this biology. However, and it has been shown, which is basically it is a very complex process of the COPD inflammation, but just to simplify it, there are two phenotypes. One is the neutrophilic, another the eosinophilic. The neutrophilic inflammation is the most common inflammatory phenotype, as already mentioned. It has been observed in the COPD. The earliest clinical trials of biologic agents in COPD targeted neutrophils and other pro-inflammatory cytokines. The anti-neutrophilic agents that have been investigated include but are not limited to, that is IL-1, IL-17, IL-8, anti-CXCR2 and human necrosis factor alpha. TNF-alpha inhibition was associated with increased risk of infection and potential risk of malignancy, and probably that is the reason it has not been advised as a standard of care in patients with severe COPD with recurrent exacerbations. The more recent trials have targeted T2 inflammation involving cytokines and chemokines, promoting eosinophilic inflammation. The eosinophilic inflammation predominates in asthma but is also present in 20 to 40% patients of the COPD. I am repeating it again and again. Why we are talking of this, the eosinophilic inflammation in the patient of the COPD. Studies with biologics in COPD have been relatively few, as most of these agents have targeted the T2 inflammation, which is less common in the COPD patient. However, cytokines referred to as alarmins, just focus on this point, basically these are alarmins, are the cytokines like TSLP, IL-33 and IL-25. This is released by the bronchial epithelial cells in response to the exposure to the allergens, microbes, air pollutions, and especially like cigarette smoke. And this is how these alarmins are released from bronchial epithelial cells, and they start the inflammatory cascade by stimulating predominantly the Th2 pathway and also the Th1 to a lesser extent. So they are present to a higher degree in COPD and important recruitment and activation of Th2 cells and T2 innate lymphoid cells too. Interestingly, COPD patients with eosinophilia has been shown to have higher IL-33 concentration. That is actually one of the important aspect in this, especially when you are talking the biologics in the COPD. The TSLP triggers T2 inflammation by activating T2 lymphocyte and innate T2 lymphocyte leading to the T2 eosinophilic inflammation. However, TSLP also been noted to trigger Th17 and Th1 lymphocyte leading to the neutrophilic recruitment and maturation. So the TSLP targets Th2 and Th1 both pathway, you must understand. Now, this is one study which actually it was quite early in 2000. This study of TNF-alpha inhibitor, basically, this infliximab on local and systemic inflammation in COPD pilot study which was conducted in year 2008, it was not a positive study. It showed that infliximab did not produce an observable disease in local inflammation in cachectic patient with COPD and had minor effects on the systemic inflammation. So it does not have a potent effect as a protective effect in the COPD. However, it has a lot of side effects. The detection of new inflammatory markers in exhaled blood condensate can help to further characterize local inflammatory processes in the COPD. Another study of the TNF-alpha, they looked at the prevention of hospitalization in the COPD, and here they used etanercept. And what the conclusion was? The finding of having the rate of COPD hospitalization associated with the use of etanercept corroborates the potential importance of TNF-alpha in the pathogenesis of COPD. This study supports the initiation of randomized controlled trial of this TNF-alpha antagonist among COPD patients at high risk of severe exacerbations. However, this still it is not been approved and no trial has actually established its efficacy in the patient with the COPD. Another very important, everybody has been using with the patient of severe asthma the use of IL-5 inhibitors, and the first IL-5 inhibitor was the mepolizumab. This basically had two studies, the Matrix and the Metrio. Both have shown that it reduces exacerbation in patients with eosinophilic associated COPD. Results suggest that blood eosinophil counts more than 150 cells at screening or more than 300 cells in the prior year allow for indication of patients with COPD who experiences exacerbations while treated with the maximal ICS-based triple maintenance therapy who are likely to benefit from the mepolizumab. However, US FDA was not convinced to advise this anti-IL-5 as a standard of care in the patient of severe COPD with recurrent exacerbation because the improvement was modest actually, and there was only 18% reduction in the exacerbation with the use of 100 mg of mepolizumab every 4 weeks, and that was not statistically significant. So it did not let it to be approved by the US FDA actually. So it is still on the trial, all the reports are a bit positive, but it's still not been approved. Another drug, benralizumab, it is also basically IL-5 inhibitor, IL-5 receptor alpha blocker, and which is a very important drug in severe eosinophilic asthma. But in the trial is still on. Here in this study, basically they had two studies, Galathea and Terranova trials, and they said benralizumab was not associated with the lower annualized rate of COPD exacerbation than placebo. Among patients with moderate to very severe COPD, a history of frequent or moderate or severe exacerbation and where the blood eosinophil counts were more than 220. So this drug also failed to be as a significant drug in the COPD exacerbations having severe disease. So just to conclude this, basically there is a Cochrane database, what they recommended in the last year actually, where they have shown the 3 studies using mepolizumab, 1530 participants and 3 used benralizumab, 4012 participants. The results, as already mentioned, the mepolizumab 100 mg reduces 19% in those with eosinophil count of at least 150 ml. When participants with lower eosinophils were included, mepolizumab was basically reducing the exacerbation by 8% only. So it was not a very significant effect. But benralizumab actually benralizumab, the data is still evolving, but the first 2 trials has been the negative one. This is a very important news, just published 1.5 months back in the New England Journal of Medicine in July 20. This is the Boreas trial, very important trial and done by one of our any Indian colleague. Basically, you know that Dr. Bhatt is there, the first name as the lead author. This is a Boreas trial, is a phase 3 double-blind randomized trial. We assigned patients with COPD who had blood eosinophil count of at least 300 per microliter and elevated exacerbation risk despite the use of standard triple therapy to receive dupilumab 300 mg of placebo subcutaneously once every 2 weeks. The primary endpoint was the annualized rate of moderate or severe exacerbation of COPD. The scores on the St. George Respiratory Questionnaire range from 0 to 100, where the lesser score was a healthier one, means better. And the ERS score, the evaluating respiratory symptoms in COPD, and 0 to 40 scale, where the lesser score was a better one. So lower scale is a score indicating the less severe symptom. Total of 939 patients underwent randomization, 468 to the dupilumab group and 471 to the placebo group. And what it showed? The annualized rate of moderate or severe exacerbation was 0.78 with dupilumab and 1.1 with placebo. And p value was highly significant. You can see here the p is 0.001. And if you look at the pre-bronchodilator FEV1, it is basically the 160 ml with dupilumab and 77 ml with placebo. Here again the p-value is very significant, 0.001. At week 52, the SGRQ score was also significantly less with mean of minus 9.7 in comparison to the minus 6.4. Again the p-value was 0.002. It is significant. If you look at the evaluation of the respiratory symptom and COPD score, this is minus 2.7 in comparison to minus 1.6. Again the p-value is significant. So, first time any biological is showing a significant reduction in exacerbation, improvement in symptoms, and that is the dupilumab. And it's just been published. And this is basically the press release by the Sanofi a couple of months back. That basically they concluded the 30% reduction in moderate or severe COPD exacerbation over 52 weeks was the primary endpoint which was achieved with this drug. 160 ml improvement in lung function of baseline versus 77 ml. Numerical improvements were observed as early as 2 weeks. Very early effect is there with the dupilumab versus placebo through the 52 weeks, and 9.7 improvement in health-related quality of life and 2.7 point reduction in respiratory symptom severity. So this drug has clearly shown its effect in the eosinophilic subtype of COPD where they are having the recurrent exacerbations. Another drug, the estigolimab, basically an anti-ST2 which has got indirectly effect over the IL-33 also. This drug, I will not go into detail, just go the inpatient with moderate to very severe COPD, estigolimab did not significantly reduce exacerbation rate, but did improve the health status compared with placebo. This drug is in the early phase of the development. However, this conclusion actually they have mentioned in the trial, in patients with moderate to very severe COPD did not significantly reduce the exacerbation rate, but did improve the health status. IL-33 is another alarming cytokine release from the bronchial epithelial cells in response to allergen, microbes and air pollutants, and treatment resulted in non-significant reduction in exacerbation frequency with a reduction in eosinophils and mild improvement in lung function. Interestingly, in a subgroup analysis, basically, it has shown those patients who are having elevated blood eosinophils, there are better improvement in the forced expiratory volume in 1 second. This is another, basically, there are two studies, Aliento and Arnasa, basically for this estigolimab in patients with COPD and is still continuing. Actually, this complete data is not out. Another very important drug, the safety and efficacy of atipicumab in patients with moderate to severe COPD, a genetic association study and randomized double-blind phase 2A trial. And what is the finding? The genetic analysis demonstrated association of loss of function in IL-33 with reduced COPD risk and gain of function in IL-33 and IL-1, this RL1 variant with increased risk. Means where the IL-33 activity is high, there is an increased risk of exacerbation, and where it is the IL-33 levels are low, the risk of exacerbation is less. However, data is still not very clear, and basically there are few initial data which has been showing that there is a reduced exacerbation rate and improved lung function in former smokers with COPD. 2 phase 3 clinical studies are ongoing to confirm the efficacy and safety profile of atipicumab in former smokers with COPD. So this drug is still in evolution and still data is pouring in, and we have to wait for the final result. This is a phase 2 study which basically this atipicumab monoclonal antibody directed against the IL-33. There was a reduction in exacerbation frequency in reformed smokers who were frequent exacerbation. Reformed smokers, those who at least smoke 100 cigarettes in their lifetime. Given the broad biological effects of IL-33, the observed differences in treatment responses as observed in former smokers and those with high eosinophil counts highlight the complex pathophysiology of exacerbation and involvement of the multiple pathway. The inflammation in the COPD is not simple, it is very complex, where various mechanisms are there, and that is the reason we have not been successful in reducing the inflammation in most of the patients. One very important aspect, The activation of immune cell proteasomes in peripheral blood smokers and COPD patients. There are basically the implications for therapy. The concept is that once you address this issue, probably this will help in reducing the inflammation in this patient. The result actually has shown the proteasome expression was upregulated in COPD patient as assessed by quantitative reverse PCR and mass spectrometry based proteomic analysis. Basically, its expression is upregulated and activity was quantified using basically activity based probes and native gel analysis. This basically.
Sir, sorry to interrupt. We are running out of time. We are just 5.
Bus.
For
I will just finish in 3 minutes. So basically, this is the one of the novel mechanism which is responsible for inflammation in the COPD patient. However, this analysis, basically what is the result? The immunoproteasome was distinctly activated in COPD patient on inflammatory cytokine stimulation of peripheral blood mononuclear cells in vitro. Inhibition of immunoproteasome reduced pro-inflammatory cytokine expression in COPD-derived blood cells. So this is a novel target actually where the people have started working in reducing the inflammation in the COPD. So I will not go into the mechanism actually, just this is a very important target which is going to be developed. There are new drugs which are being used for this. The proteasome basically inhibitors. The most important has been in the past which we have been using the alpha-1 antitrypsin. Now the drug which is in the process is the neutrophil elastase to prevent the development of emphysema in the patient with COPD. So just another word, this Jazbilumab in adult and adolescent with severe and uncontrolled asthma, this is very well established. A clinical trial evaluating this therapy in moderate to severe COPD is currently underway. Another drug basically MAP 38 PK inhibitors, basically this Losmapimod failed in the COPD. Another one very important aspect, actually there is inhalation therapy in the management of the COPD inflammation. And I will just skip these slides. This is another drug, this Tozorakimab by the COPD. Actually this drug, the result will be available in 2024, is still in the evolution phase. This Tozorakimab basically is a novel therapeutic agent with a dual mechanism of action that blocks IL-33 reduction and oxidation in signaling, offering potential to reduce inflammation and epithelial dysfunction in the human disease. Via inflammation, this is basically inhalation therapy, monoclonal in the inhaled form is being developed, and probably we are going to get the data in the next few years. So I will just skip these slides to conclude. Chronic and rare inflammation is central to the pathogenesis of COPD, and there is a shortage of targeted treatments that successfully modulate the key inflammatory pathway. However, with the data available of the Dupilumab, probably we will have this drug in future for the management of severe exacerbation. Advancing in understanding the pathophysiology of COPD have led to the several novel biologic and small molecular therapies that have attempted to address the immune inflammatory process. No biologic, as already mentioned, and the study already suggests that at least a subgroup of patients may benefit not only in terms of reducing exacerbation, but hopefully also in reducing their dependence on the oral corticosteroids and their attendant significant side effects. There are several ongoing investigations for numerous treatment targets upon which we could potentially await. So with these words, I'd like to thank all of you for the patient hearing. If there are any questions, I can take.
Thank you, sir. Thank you for such a thought-provoking discussion and sharing new insights in management of COPD. Sir, in Mepolizumab, we can see this reduction of 19% in exacerbation.
Yes.
What about symptom control and severity of symptoms? Is there any difference?
Not
like we saw in
Yes.
Dupilumab, there was improved quality of life.
In Mepolizumab, there was no improvement in lung function. There was reduction in exacerbation by 19%. So significant, in that way it was not very significant. That is the reason FDA denied its approval.
So,
Sir, in which phase of COPD we can start these biologics? Because these are the
Basically, in the patient with COPD where you have 3 exacerbations in the last year, patient is having a recurrent hospitalization, and patient is on the triple drug therapy, and all other factors you have taken care of in these subgroup of patients, as you are doing in the use of biologicals in the asthma, where you have taken care of all the symptoms, basically, and also the environmental control, the other factors. You have taken the patient is adherent to the therapy, the technique is correct of the inhalation, and also your patient is not smoking, all these factors. Trust has to be there, then, and patient is on the triple therapy. Then you add these biologicals, but still they have not been approved. Probably in the future we'll have dupilumab. Another IL-5 inhibitor, depemokimab, I have not mentioned there. Actually, this is one IL-5 inhibitor which will be used as once in 6 months. One injection for 6 months, you don't have to give any drug. And this is important for the subgroup of COPD patient where the eosinophil number is more than 150 at least or more than 300. They are the responders for this type of therapy, anti-IL-5.
So any questions from the house? Actually, we must be, before using biologics, we must be very clear regarding our diagnosis, whether it's asthma, whether it's COPD. After we have clear-cut diagnosis, what is the type of inflammation, whether it's TS2, non-TS2. As we can see, very good role of biologics in asthma. We have a lot of drugs for eosinophilic inflammation. So from the discussion, we can see we don't have so much good options of biologics in COPD. So, sir, besides this duplimab, I think all of the biologics have not shown any
Not shown, but probably we will have tezepelumab also, since it reduces the basically action of the TH2 pathway and also the TH1 by inhibiting the IL-17 and IL-2 basically. Basically IL-1 and IL-17 both. So in that way, the neutrophilic inflammation and the eosinophilic inflammation both will be reduced with the use of tezepelumab. So although trial is still on, we don't have data. So we have to see the result of this tezepelumab trial in the COPD.
So anti-TSLP, tezepelumab is very promising drug. So now any question from the audience?
Sir, in our country, most of patients, almost 20-30% of patients are with overlap. But what we saw in previous trials that mepolizumab and benralizumab failed in patients of COPD. But dupilumab succeeded. So what will be the underlying mechanism?
Actually, still this data just been basically released last month only. So still the things are being evaluated. Probably we need to see, as already mentioned, that it is the 20 to 40% of COPD patient where the eosinophilic inflammation is important and relevant. Probably that is the reason in the mepolizumab data, what they have used, that even those who had less than 150 eosinophil count per cubic mm, and they have used, and they failed because most of the patients were from the same group. So neutrophilic inflammation is the predominant one, and if you look at the basically, if you are giving to all the patients of COPD, is going to fail. However, in the eosinophilic group, there was a basically reduction in the inflammation, but not up to a level which was expected from the bemralizumab or the benralizumab. However, the benralizumab 2 trials are still on. I have just shown the slide, I have not gone into detail, but this data will be available in the next coming 1 to 2 years.
Thank you so much, sir. We are coming at the time. So next speaker is the Rajesh Prasad, sir. Okay.
Thank you, sir. That was very informative session. Now I would like to invite Professor Rajendra Prasad, sir, and Dr. Ved Prakash, sir, to come on the stage and felicitate our speaker, Dr. B.P. Singh, sir. Now I'd like Now I would like to invite our chairpersons on stage and get felicitated. Dr. Rakesh Chaudhary, sir. Dr. Rahul Srivastav, sir. Dr. Ravi Bhaskar, sir. We will begin our inauguration ceremony in a while.
ये चाय बनाने वाला मथुरा का है सर। वो वो मथुरा का रहने वाला है जो चाय बनाता है सर। वहाँ पे गन्ने की मिल है, उसी के पास गांव है उसका। अब उससे कहना पड़ेगा, वहाँ उसे तो ऐसे मिल जाती है वहाँ पे चीनी मिल की वजह से। नहीं, इसका ध्यान रखें भाई, जो भी चाय बना रहे हैं मथुरा वाले। आप सभी से एक इन्फॉर्मेशन शेयर ये करनी है कि वाइस चांसलर मैडम शॉर्टली आने वाली हैं और जो डीन हैं वो भी आने वाले हैं और अदर डिग्निटरीज भी आ रहे हैं। तो आप सभी लोग बैठे रहें और थोड़ा सा स्टेज पे जो चेंजेस होने हैं वो ये हमारी टीम कर लेगी जल्दी से। और इनॉग्रेशन सही 11 बजे प्रारंभ हो जाएगा, तो 15 मिनट का समय है। मैंने अनुरोध किया है प्रोफेसर राजेंद्र प्रसाद सर से कि उनकी जो टॉक है वो शिफ्ट कर लें थोड़ा सा, जस्ट आफ्टर इनॉग्रेशन आपकी टॉक करा देंगे। तो हाँ, चाय अभी उनको दिलवा देते हैं सर। तो जब तक आप चाय पिलवाइए सभी को और सभी लोग बैठे रहें, बस थोड़ा सा चेंज करना होगा और वी विल स्टार्ट इनॉग्रेशन। थैंक यू।
To all of you, thank you, Dr. Ved Prakash sir, for inviting all us here for a academic program on update of COPD. In first speaker, Dr. BP Singh sir, as we all know, is the
Teachers and my colleagues, a very good morning to one and all. Well, Ask questions, share your views, experiences, and enlighten us.
COPD, we can control the symptoms and control the disease process and the progression. So we have to work for the preventive strategy.
Thank you, sir. Now, I would like to invite chairpersons for our first session. Dr.
Good morning to all of you. Thank you, Dr. Ved Prakash sir, for inviting all us here for a
Sir, that was very informative session. Now I would like to invite Professor Rajendra Prasad sir and Dr. Ved Prakash sir to come up.
ये चाय बनाने वाला मथुरा का है सर। वो
Once again, welcome everyone. We'll begin the inaugural function by inviting on stage our esteemed dignitaries who have joined us here. On behalf of department, we welcome our chief guest, Dr. Sonia Nityanand Ma'am, Honorable Vice Chancellor, KGMU. She is also a director of Ram Manohar Lohia Institute, Professor, Head of Department of Hematology, SGPGI. She is a renowned immunologist and did PhD in Immunology Hematology section. She did her MBBS and MD in Medicine from KGMU. We are grateful to her for accepting our invitation and becoming the chief guest for today's event. Welcome, ma'am. Taking our event further, we heartily welcome our guest of honors for the event. We cordially welcome Professor Rajendra Prasad Sir, Organizing Chairman, COPD Update 2023, Ex-Director, VP Chest Institute, Emeritus Professor, National Academy of Medical Sciences and Director Medical Education, and Professor, Department of Pulmonary Medicine, Eras Medical College and Hospital, Lucknow. Next, we invite our guest of honor, Dr. Amita Jain Ma'am, Dean Academic and Head of Department of Microbiology, KGMU, Lucknow. We also invite, next we invite our guest of honor, Dr. Rahul Chandola Sir. He is a founder of Delhi Heart and Lung Institute. We also invite on the dais a guiding force and mentor, Dr. Ved Prakash Sir, Head of Department of Pulmonary and Critical Care Medicine, KGMU. Now we request our organizing secretary, Dr. Ved Prakash Sir, to felicitate our esteemed dignitaries with saplings. First, I request him to felicitate our chief guest, Dr. Sonia Nityanand Ma'am. I request him to felicitate our Dean, Dr. Amita Jain Ma'am, with the sapling. I request him to felicitate our organizing chairman, Dr. Rajendra Prasad Sir. Now, I request him to felicitate our chief guest, Dr. Rahul Chandola Sir, with the sapling. According to our tradition, may we request our esteemed members seated on the dais to kindly inaugurate the event formally by lighting of the auspicious lamp. And let's pray to God that we may continue to burn the auspicious light that may bring in happiness, prosperity, and healthy long life to the people of India and around the world.
अज्ञानता से हमें तार Amita Ridima.
Thank you for this beautiful recitation. Now I would like to invite our organizing chairperson, Professor Rajendra Prasad sir, to kindly give the welcome address.
Good morning. Chief guest of today's function, our own, I must say, Sonia Nityanan, who has become now Vice Chancellor of this very prestigious medical university. Then Dean of this medical university, again, our own Dr. Amita Jain. We have worked together for very long years in KGMC. And then a guest of honor, Dr. Rahul Chandola. I think it is his second visit coming to this department and this institute. And then Dr. Ved, who is organizing secretary of this COPD update. And then many distinguished people are sitting off the dais. Very senior person, Dr. V.B. Singh, Dr. K.B. Gupta, Dr. B.P. Singh Kushwaha, and so many. So, and all the participants and my dear students. You know, this COPD update is being organized on the occasion of World COPD Day, which happens to fall on every Wednesday of November every year. So that was on 15th of November, and because of the festival season, this update was postponed a little bit on 17th. You know, the COPD, if I have to say, is a very common disease globally as well as in India. If you see the latest figure of COPD, globally, around 38 crores are suffering. And if you the Indian figures, whatever global burden of disease, India and state-wise burden has been done in 2019, that shows that in India around 5.5 crores, means 55 lakh, they suffer from COPD. Death-wise also, large number of people die globally, about, as you have heard, about 3 million, more than 3 million. In India, around 8.5 lakh people die with COPD. Immediately, if I compare with tuberculosis, because World TB report just came about 3-4 days back, 23, and that says that in India, tuberculosis is around 27-28 lakhs. So COPD is just double that. And death is also around 3 to 4 lakh. And here death is. And now come down to the state of Uttar Pradesh. In that global burden of disease, which they went to the state-wise further, and what is projected there, UP, of course it should be that UP, since the highest population in the country, so it carries the highest number of COPD and highest number of deaths among all the states. That is natural, obvious, natural, big state and big population. So what I am trying to say with these figures, that COPD is a very chronic disease and chronic morbidity, mortality, disability it created. But it is very unfortunate, awareness about COPD is very less. That's why COPD Day was started to being celebrated, to make people aware about this disease, and because it is killing many people. And treatment, as per if I compare with tuberculosis for a moment, tuberculosis is 100% curable disease. What I say and not I say, I treated tuberculosis, lakhs and lakhs of patients in the last 45 years. But COPD is a progressive disease. It has got hardly a treatment like tuberculosis. Only we can improve quality of life by giving some drugs and other non-pharmaceutical measures. So what I'm saying, a disease which has hardly any drug to finally cure the patient, so prevention is very important. And prevention, I always say COPD is a man-made problem. If you see the risk factor of COPD, smoking, pollution, and biomass fuel, these are three major risk factors, which is all human-made problem. So what I'm saying that this can be prevented. So with these few words, I welcome you all for this COPD update and wish this update a grand success. Thank you very much.
Thank you, sir. Now I invite our guest of honor, Dr. Amita Jain, ma'am.
Our chief guest of the day, Professor Sonia Nityanand, Vice Chancellor KGMU, Professor Rajendra Prasad, Organizing Chairperson, Dr. Chandula, and Dr. Ved Prakash, very august seniors in the chest physicians list in the town, and august faculty of KGMU, and dear students, welcome to all. On this occasion of COPD update organized by Department of Pulmonary and Critical Care Medicine, I congratulate the head, Professor Ved Prakash, and his team for such a wonderful organization. As Dr. Prasad has right now said, it's a common disease, it's a chronic disease, and it's a deadly disease. So it has a high mortality. Every third Wednesday of November, we celebrate this day to make people aware of COPD, how to prevent COPD, how to treat COPD, how to manage COPD, etc. So the organization should be actually, and the updates is for us, but the organization should also be for the public to make them aware that how to prevent COPD. Once it's happened, there's hardly anything, which Professor Prasad has already said, there's hardly anything which we can do. So I expect from each one of you to be a crusader, go in public, talk to people, tell them that what habits are not good, how you can prevent COPD, etc. Just on the lighter note, before we came here, we were discussing that what is the difference in pulmonary and respiratory medicine. So we have two departments with two heads, with two similar things. But I think if we kind of take COPD ahead and look at the pulmonologist, pulmonary critical care medicine to manage it very well, that will be a big achievement. Once again, I congratulate all of you. Have a good academic feast, and thank you for inviting me.
Thank you, ma'am. We now invite a guest of honor, Dr. Rahul Chandola, sir, to share his thoughts on the occasion.
Thank you so much for inviting me here. Good morning, everybody. I would take this opportunity and the special occasion, the World COPD Day, to talk something about my domain, which is the transplantation. Madam, actually, when VC ma'am first met this morning, the first thing was she was remembering a colleague of hers, a cardiothoracic surgeon, who in COVID times unfortunately had florid COVID infection involving the lungs, and probably was on ECMO for a long time, and because the cadaver organ donation program is the one that can save millions and millions of patients like that who are suffering from end-stage lung disease. Unfortunately, in the dearth of suitable cadaver organ, the lung, he had to give up his life. But if in our country, fortunately, the cadaver organ donation program is coming up very nicely, and you'll be surprised that the number of organ donations that were like 1 or 2 way back, in 2015-14 in the north. they've gone up to 20 to 25 in a month, which is quite a leap forward. And, and all of us who are meeting here today, probably this is a good opportunity for us to talk to VC ma'am. If we want, we can really make a difference. And this KGMC, because we know there are so many brain dead donors here. But I believe, in Lucknow itself, in a night there will be like 7, 8 brain dead donors, potential donors, which are not being tapped so far. But if we run a good campaign and we start from KGMC itself, KGMC has taken a leap before also. I remember way back Dr. Ved was also involved, and at a time there were like 8 to 10 donations in 6 months' time from KGMC. I think the potential is much more, and we all can come together to promote this cause. And remember, one organ donation, and one effort by a team member can actually save 8 lives. One yes from a patient's, the donor's family can actually save 8 lives. 2 lungs, 1 heart, 1 liver, 2 kidneys, pancreas, intestines, and so many tissues, that can be derived from one organ donor. So that's something really amazing, and I hope we can develop this program in KGMC again. We can revive the program again, and we can really make a difference in people's lives. With that, stand up. Thank you so much, ma'am.
Thank you, sir. Now we invite our chief guest for the event, Dr. Sonia Nityanand ma'am, Vice Chancellor KGMU, for her blessing and message.
Thank you. Dr. Amita Jain, who's the Dean Academics and Head Department of Microbiology. Professor Rajendra Prasad, the ex-director of VPCI New Delhi and the Emeritus Professor Pulmonary Medicine, Eras Medical College, Lucknow. Professor Rahul Chandola, a senior CTVS consultant and the founder chairman of the Institute of Heart and Lung Diseases and Research Center, New Delhi. Dr. Ved Prakash, Professor and Head, Department of Pulmonary and Critical Care Medicine. Many other eminent faculty members in the audience and participants and staff of this department. At the outset, a very warm welcome on the behalf of the King George's Medical University to this very prestigious function on COPD, World COPD Day, which was, I believe, to be held on November 15th. But because of the holiday season, it is being held today. And I would like to congratulate you, Dr. Ved Prakash, to organize this one-day conference today, one-day program today. And I would like to begin by urging this audience on 2 issues. Even all of us, I think there must be about 100 people here today, maybe 75 people, 75 to 100 people. If we just pledge for 2 things, I think that will make this CME worthwhile. The first thing we all, before we step out, should pledge, like Dr. Rajendra Prasad highlighted, that one of the most important causes for COPD, which is preventable, is smoking. So if today all of us who are present in the audience decide to step out and be the messiahs of creating awareness against smoking, and also at the same time for early detection of tuberculosis and a complete treatment of tuberculosis. These are the 2 most important, at least for all the common participants who are here, who may even not be medical, may at least spread this word in the public, and we have our media friends here who may also want to spread this word on prevention of smoking. The second message for today which I want to give, and again I want all of you to pledge, which Dr. Chandola actually touched upon. The ultimate treatment for people who develop COPD due to whatever cause is lung transplantation. On one side, we at the university are gearing up to establishing the infrastructure and making a team for lung transplantation. That's our job. But what is your job? Your job is to create awareness about organ donation. That is where you people, we have to work like a team. Your job is to create awareness that organ donation is the right thing to do. I know that in this university, prior to COVID, the organ donation program was very active. That's what you were mentioning. And again, we have to, during COVID times, a lot of these activities died down. But again, we have to restart the organ donation program here, because this is the right place. We have a huge influx of people into the trauma and emergency center where a lot of people are brain dead, and we have to motivate them. We have to create awareness about giving organs. So these are the only two take-home messages that I would like you people to join hands with us and to spread. One is about organ donation, and two is about preventive health, especially in relation to COPD. So with this, I would like to congratulate you again, Dr. Ved Prakash, for organizing this conference today. I hope you all have a good experience of gaining expertise and knowledge from people who have come to lecture. I can see it's a very nicely organized program. So thank you very much.
Thank you, ma'am. Now I request Dr. Ved Prakash sir to facilitate our dignitaries with memento.
Thank you, Shubhra. I would request Professor Rajendra Prasad sir to deliver his book written by him on manual of chest X-ray to Honorable Vice Chancellor ma'am. So please present, sir, please present your book. Two volumes, and there is a coffee table book also of Professor Rajendra Prasad sir. I will request to present the coffee table book also.
Now I request Dr. Ved Prakash sir to facilitate Dr. Sonia Nityanand ma'am with the memento. Ma'am, please come forward. Now, I request him to felicitate Dr. Amita Jain, ma'am. I request him to felicitate Dr. Rahul Chandola, sir. Now I request sir to felicitate Dr. Rajendra Prasad, sir. I would request Dr. Sonia Nityanand ma'am to felicitate Dr. Rajendra Prasad, sir. Now I request VC ma'am to felicitate Dr. Ved Prakash, sir. Now, I would like to invite Professor Ved Prakash, sir, Organizing Secretary, Head of Department of Pulmonary and Critical Care Medicine, to give vote of thanks.
Thank you, Dr. Subra. This is a very important occasion to create awareness regarding the deadly disease COPD, causing more than 38 crores. This is a big number. Worldwide, more than 38 crores are suffering from COPD, and in India, more than 5 crores are suffering from COPD. One of the most deadly disease and projected to be the third killer worldwide up to 2030. So, as you all know, there is no cure. So, prevention is the key, and early detection and management of COPD is, I can say, the key message today. हमारे लोग जो स्मोकिंग कर रहे हैं, अभी मैम ने प्लेस करने को कहा, मैं आपको कहना चाहता हूं मैम कि इस पर 2000 से ज़्यादा लोगों को इसकी लिंक भी है, जो YouTube पे इसकी लाइव स्ट्रीमिंग हो रही है कार्यक्रम की। तो आपकी आवाज़, आपकी जो रिक्वेस्ट है, मुझे लगता है दूर दूर तक जाएगी। और इस अवसर पर मैं, बीइंग हेड ऑफ दिस डिपार्टमेंट, आई प्लेज टू डोनेट माई ऑर्गन्स। So, I will donate my organs. I pledge to donate my organs whenever I found brain dead. So, I will also request from our team, ma'am, 256 team members of this department, there is a strength. So, I will request them also to come forward and to donate the organs. I would like to thank our Honorable Vice Chancellor ma'am, जिन्होंने हमें इंस्पायर किया इस प्रोग्राम को स्टार्ट करने के लिए, इसको आगे लाने के लिए, और जब हम लोगों ने मैम से रिक्वेस्ट की तो उन्होंने एक जहाँ तक जितनी आवश्यकता थी उतना सहयोग इस प्रोग्राम को स्टार्ट करने के लिए जहाँ जहाँ बात करने की आवश्यकता थी वहाँ सभी जगह पे आपने किया है। और मैं इस ओकेजन पे, क्योंकि COPD का जो अंतिम जो ट्रीटमेंट है वो अभी सभी ने कहा कि ऑर्गन ट्रांसप्लांटेशन है, लंग ट्रांसप्लांटेशन है, जो कि बहुत डिफ़िकल्ट टास्क है। और इस चैलेंज को हम लोगों ने एक्सेप्ट किया मैम की लीडरशिप में, मैम के इंस्पायर करने की वजह से। क्योंकि जैसे ही मैम ने यहाँ ज्वाइन किया तो उनका ये थॉट था कि ऑर्गन डोनेशंस भी बढ़ें और हम लोग इस ट्रांसप्लांटेशन को भी आगे बढ़ाएं। जब मैम लोहिया में थी, RML की डायरेक्टर थी, तो वहाँ की एक डॉक्टर को आपने सभी ने पढ़ा होगा, उन्होंने बहुत प्रयास किया ऑनरेबल चीफ मिनिस्टर से, मुझे लगता है कि 1 करोड़ से ज़्यादा की सहायता भी दिलवाई और उनको एयरलिफ्ट किया गया था। एक डॉक्टर थी, रेजिडेंट डॉक्टर थी, लेकिन हम लोग उनको बचा नहीं सके। मैं इस अवसर पर जहाँ तक भी, क्योंकि 2000 लोगों को इसमें लिंक भी शेयर किया गया है, जहाँ तक भी मेरी आवाज़ जा रही हो, मैं विभाग की तरफ से मैम आपको आश्वस्त करता हूँ कि ज़्यादा से ज़्यादा डोनेशंस हमारे विभाग के लोग सबसे पहले इसके लिए प्लेज करेंगे और आप सब भी इस पुनीत काम में आगे आएं। इसको इंस्पायर करने के लिए मैम मैं आपका बहुत बहुत धन्यवाद देता हूं कि आप हमारे बीच में एक इंस्पायर करने के लिए हम सभी को आप हमेशा हमें समय देती हैं। बहुत बहुत धन्यवाद कि आपने आज समय निकाला यहाँ पे आने के लिए। हमारी डीन प्रोफेसर अमिता जैन मैम, जब भी हम लोगों को कोई समस्याएं होती हैं तो मैम सॉल्व करती हैं। हम लोगों के लिए एक बैकबोन की तरह से डिपार्टमेंट के लिए हमेशा खड़ी रहीं। जब भी हमने याद किया हमेशा उन्होंने सहयोग दिया है, अपनी प्रेजेंस हमेशा हमारे कार्यक्रमों में रखी है। मैं आपको बहुत बहुत धन्यवाद देता हूं मैम यहाँ आने के लिए। डॉक्टर राहुल चंदोला जो फाउंडर डायरेक्टर हैं इंस्टीट्यूट ऑफ हार्ट एंड लंग डिजीज़ के, आप दिल्ली से चल कर के हमारे इनविटेशन पर यहाँ पे आए। हार्ट लंग के बहुत ही फाइनेस्ट ट्रांसप्लांट सर्जन हैं और जहाँ से पहला लंग ट्रांसप्लांट हुआ था कनाडा में, उसी सेंटर से आपने ट्रेनिंग ली और 6 साल तक वहाँ पे सर्व किया है आपने। और यहाँ पर आकर के देश में किस तरह से इस कार्यक्रम को आगे बढ़ाया जाए उसके लिए लगातार आप प्रयास करते हैं। मैं आपका अभिनंदन करता हूं सर और बहुत बहुत धन्यवाद देता हूं कि शॉर्ट नोटिस पर आपने हम लोगों को ज्वाइन किया यहाँ पर। बहुत बहुत धन्यवाद। टीचर ऑफ टीचर्स, एज आई से, हम सभी के गुरु प्रोफेसर राजेंद्र प्रसाद, किसी परिचय की आवश्यकता उनको कभी नहीं होती है और हमेशा ही हमारे जितने भी समस्याएं होती हैं उनमें मार्गदर्शन करना और विभाग में जब भी कार्यक्रम होते हैं एज ए चेयरपर्सन उसमें पूरा सहयोग करना, मार्गदर्शन करना, ये आप लगातार करते हैं। मैं आपको बहुत बहुत धन्यवाद देता हूं कि आप हमेशा ही हमारे लिए एक इंस्पायरिंग बैकबोन की तरह से आप खड़े होते हैं। हमारे प्रोफेसर KB गुप्ता साहब हमारे सामने हैं जो रोहतक में हेड ऑफ डिपार्टमेंट थे, अभी आप लखनऊ में हैं। आपका मैं बहुत बहुत स्वागत करता हूं, बहुत बहुत धन्यवाद देता हूं कि आप आए सर। डॉक्टर BP सिंह जी, मैं बार बार कहता हूं कि जब भी किस तरह से एकेडमिक और रिसर्च को साथ साथ प्रैक्टिस में भी आगे रखना हो तो ऐसा हम लोग डॉक्टर BP सिंह सर से सीखते हैं हमेशा। मैं आपको बहुत बहुत धन्यवाद देता हूं सर कि आप आए। डॉक्टर सिंह साहब यहाँ पे मौजूद हैं, 63 बैच के जॉर्जियन हैं, सबसे सीनियर मोस्ट जॉर्जियन हमारे बीच में। चेस्ट के फिजिशियन में अगर कहूँ लखनऊ के तो सर ही हैं और सर आप यहाँ पर मौजूद हैं, सभी सीनियर्स का प्रतिनिधित्व करते हुए आप आए हैं सर, मैं आपको बहुत बहुत धन्यवाद देता हूँ। डॉक्टर अम्बरीश जी जो कि हमारे CBTS के सर्जन हैं और वैस्कुलर सर्जरी के हेड ऑफ डिपार्टमेंट हैं, आपका बहुत बहुत धन्यवाद देता हूँ कि आपने समय निकाला, आप आए। डॉक्टर एस के द्विवेदी सर जो हमारे टीचर हैं और आपने समय निकाल करके हमेशा ही विभाग के लिए, हम लोगों के पेशेंट्स के लिए हमेशा ही आप मदद करते हैं सर। आप अपना समय निकाल करके आए, मैं आपको बहुत बहुत धन्यवाद देता हूं सर कि आप हमारे बीच में हैं। डॉक्टर विजय कुमार सर, हेड ऑफ डिपार्टमेंट, आपका भी स्वागत करता हूं। प्रोफेसर चतुर्वेदी सर जो हमारे टीचर हैं, अरुण चतुर्वेदी सर, आप समय निकाल करके आए, मैं आपका धन्यवाद देता हूं। सभी का नाम नहीं ले पाऊंगा, बहुत सारे सीनियर लोग हमारे बीच में हैं, प्रोफेसर्स और जो डिग्निटरीज हैं, मैं आप सभी को धन्यवाद देता हूं कि आप सबने अपना समय निकाला हमारे लिए। जो ल्यूपिन हैं जो सपोर्ट कर रहे हैं इस प्रोग्राम में, आपका भी धन्यवाद देना चाहता हूं। और मीडिया का चूँकि अवेयरनेस के लिए हम लोगों ने रिक्वेस्ट की थी और बढ़ चढ़ करके मीडिया इन सरोकारों को लगातार निभाता है समाज के लिए। आपकी बहुत अग्रणी भूमिका है। मैं सभी मीडिया कर्मियों का जो अलग अलग मीडिया हाउसेस से यहाँ पे हैं, मैं आप सबका धन्यवाद देता हूँ कि आपने इस संदेश को दूर दूर तक लेकर के गए हैं। मुझे लगता है कि आने वाले समय में अगर हम सभी लोग, समाज के हिस्से जितने भी हैं, सब अगर अपने हाथ, वी विल जॉइन हैंड्स फॉर दिस प्रोग्राम। और मैं एक बात यही कहना चाहता हूँ कि जितनी हम लोग मेडिकल टूरिज्म की बात करते हैं देश में, अभी तो हम लोगों ने कहा कि हम लोग मेडिकल टूरिज्म कर रहे हैं गरीब देशों के लिए। यदि हम लोग डेवलप्ड वर्ल्ड की तरफ इस प्रोग्राम्स को एक्सटेंड करना चाहते हैं, अपने मेडिकल टूरिज्म को वहाँ तक पहुँचाना चाहते हैं, तो ऑर्गन ट्रांसप्लांटेशन इज़ द एरिया टू एक्सप्लोर कि जो बैकबोन साबित हो सकता है इस प्रोग्राम के लिए। और अगर आप चाहते हैं कि अमेरिकन्स और ब्रिटिशर्स या और भी बड़े कंट्रीज़ के लोग यहाँ पर लाइन लगाएं, तो मुझे लगता है कि यही एरिया है जहाँ पर हम लोग इसमें आगे बढ़ कर के अपने देश की पूर्ति भी कर सकते हैं। और इतने ब्रांडेड हमारे पास आते हैं कि हम लोग इसकी जो ग्लोबल नीड है उसमें भी अपना योगदान दे सकते हैं। तो इस अवसर पर मैम जो आपने एक प्लेज करने के लिए कहा, उसमें मैं सभी से, जहाँ तक भी मेरी आवाज़ जाती होगी आज, मैं सबसे अनुरोध करता हूँ कि सब लोग ऑर्गन डोनेशन के लिए प्लेज करें, स्मोकिंग को रोकने के लिए प्लेज करें। आधे लोग स्मोकिंग की वजह से COPD की जद में आ रहे हैं। मैं फिर कहता हूँ कि कितना हमारा पॉल्यूशन है, एयर पॉल्यूशन, जो एक इंडिविजुअल के हाथ में नहीं है, ये सामूहिक जिम्मेदारी है। लेकिन स्मोकिंग ये हमारी अपनी समस्या है, इसको हम लोग क्विट करें। माताएं बहनाएं जो चूल्हे पे खाना बना रहे हैं, बायोमास फ्यूल एक्सपोजर की जद में आकर के COPD की चपेट में आ रही हैं, उनके लिए भी मैं कहूँगा कि कम से कम वेंटिलेशन की व्यवस्था ज़रूर रखें। यदि चूल्हे पे खाना बनाती भी हैं तो चूल्हे को कहीं बाहर की तरफ कोशिश करें रखने की, जिससे कि धुआं घर में ना भरे, वहाँ पर धुआं इकट्ठा ना हो। ये मेजर रिस्क फैक्टर्स हैं हमारे, इनके लिए एड्रेस करने के लिए हम सबको आगे आना चाहिए। मैं आप सभी का पुनः धन्यवाद देता हूँ। वाइस चांसलर मैम हमारे लिए इंस्पिरेशन हैं, मैं आपको बहुत बहुत धन्यवाद देता हूँ कि आपने इस कॉज को आगे लेकर के गई हैं। और ऑर्गन डोनेशंस और ऑर्गन ट्रांसप्लांटेशन में KGMU मुझे लगता है कि देश का नेतृत्व करने की तरफ आगे बढ़ेगा। इस तरह की अपेक्षा और उम्मीदों के साथ मैं अपनी बात समाप्त करता हूँ। बहुत बहुत धन्यवाद।
Thank you, sir, for sharing the insight. Shall we all stand up for the national anthem?
जनगण मन अधिनायक जय हे भारत भाग्य विधाता। पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा। विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा। तब शुभ नामे
Thank you, everyone. We will be starting our academic session in a short while. Please be seated. Snacks will be served here itself, so please be seated. Dr. Rachit Sharma, Sir, Assistant Professor, Respiratory Medicine, Eras University. Dr. Vipul Prakash, Sir, Senior Consultant, PCCM, Medanta Hospital. Dr. Rajneesh Srivastav, Sir, Senior Consultant, Pulmonary Medicine, Sahara Hospital, Lucknow. Dr. A.K. Singh, Sir, Senior Consultant, Pulmonary Medicine, Chandan Hospital. Dr. A.K. Singh, Sir, Senior Consultant, Pulmonary Medicine, Chandan Hospital.
Our next speaker is Professor Dr. Rajendra Prasad, sir, who actually needs no introduction. He is Guru of Gurus, as very rightly said by Ved Prakash, sir. He had been head of department and director of many eminent institutions, including VP Chest Institute and KGMU, Lucknow. He is a great author, great teacher, and we are here. He has received many eminent and great awards like BC Roy Award. So we will be honored to listen his talk on epidemiology of COPD. Over to you, sir.
So, good afternoon. After very exhaustive inauguration, I must say, now we have again started the CME program, and I would like to thank Dr. Ved to have organized this CME. And I happens to be the opening batsman, but then I asked Dr. BP Singh, you please open, and I will subsequently do the things. So my talk has been, I think, rush through the slides because I have also catch a flight this afternoon. And most of the thing has been said about the epidemiology and risk factors of COPD. Even I said during my inaugural address. But to show you some slides, you know, especially the youngster, I make this slide. And I used to say that many people ask from us, sir, how you have become like this? So I said, I follow this rule. If you want to shine like a sun, first you have to burn like sun. This is for a youngster. Without doing a hard work, nothing is possible. Then I say another sentence, better than 1,000 days of diligent study is one day with great teacher. I'm not great teacher, but for whom, and this I learned when I was in Japan way back in 1809. This is Japanese proverb. And so I say it for my own teacher and for my own mentor. He's no more. I always pay tribute to him before starting a lecture. And I was very lucky that just 1 month before death, he was in Era Medical College during the National CME and Drug Resistance. And he was given a standing ovation where who's who of this, including Chaudhary, Behra, many people attended that National CME. And I was very happy that I have been able to give him respect during that conference. These are my institutes which I am supposed to work. Word COPD, although 24 guideline also has come, but 23 guidelines already say, you know, when you see your OPD, chest OPD, any OPD, medicine, chest, this type of patients are not very uncommon. Usually we ask our student, have you seen the patient chest in a lateral profile? Many of us आजकल भूलते चले जा रहे हैं. So if you see the lateral profile, AP diameter is increased, and then you find that Hoover sign हर बच्चा बोलता है. This is what Hoover sign is, and such type of X-rays, overinflated chest, and such type of CT scans showing all sort of emphysema, centrilobular, panlobular. They're not uncommon in our day-to-day clinical practice, clinical OPD. So that's why I said it's a very common disease. And first time, COPD was actually started way back in 1959 with SIVA Symposium. Obstructive airway disease is comprised of chronic bronchitis and emphysema. Ultimately, this name has been changed and definitions also has been changing. And and if you read the definition, probably you can understand what COPD is. If you read the first definition, that chronic obstructive pulmonary disease, state characterized by airflow limitation, it is still true. That is not fully reversible, it is still true. The airflow limitation is usually both progressive, it is still true, and associated with abnormal inflammatory response of lungs to noxious particles of gases. Everything is even true, which was when it was first time defined in 2005, subsequently keeps on changing, but essentially the definition remained the same. This is a definition of 2023 guideline. As I said, it quite underestimated disease. It is diagnosed very late. I have already shared you that large number of people are suffering, around 38 to 39 crore globally. They have about 3 million deaths globally is happening. And in India also it is large number of studies has been conducted, and that shows that ranging from 2 to 22%. Many studies in India, including Dr. Jindal's paper and everything, has shown that it's there. And then death I talked. This is the death figure, and COPD death absolutely is in India. India and China you see, but India about 0.84 million, means 8 lakh से ऊपर लोग मर रहे हैं. And when you see the state-wise, it was broken. I said in my inaugural address, Uttar Pradesh stands at the top. Out of 5 million Indian figure, we have around 1 million Uttar Pradesh, more than 90 lakhs. So that was the story of state-wise and rural, urban, all sorts of epidemiology has been. Even we did a study 2003, COPD in rural Lucknow came out to like this. And so what I'm trying to say, there's an enormous burden in terms of morbidity, disability, and mortality. You must have understood this. I said I will cut short my lecture because I have also catch a flight. And then what are the risk factors? Another point. We have already, I think everybody has dealt with the risk factor. The Sonia madam has also dealt. I also talked about. There could be many risk factors, but tobacco smoking, exposure to biomass fuel, and the environmental pollution. These are the 3 major risk factors for COPD. And which are all preventable. I said it is all preventable. It is all human-made. Smoking we are doing. Environment pollution many times we are creating. So household, we are doing that. So everything is a man-made problem. There has been large number of studies smoking and COPD. In India there are different smoking habits. Bidi is a very common, I say, and this is Bidi smoking, people think that Bidi is small and having the natural look, probably it is less hazardous. Actually, this study was done by us in KGMC, a case control study on chronic study of smoking and crime. We find that even COPD has similar risk, whether you smoke Bidi, whether you smoke cigarette, although the tobacco content in bidi is 1/4 of a cigarette, but still it is, so sometimes I say that in one of the papers says that bidi smoking is much more dangerous than the cigarette smoking, if you compare weight to weight. So even in India, कई लोग हमारे पीजी लोग पूछते हैं साहब सिगरेट पीते हो, मना कर देता है, किताबें ये विदेश की पढ़ते हैं सब, विदेश वाले बीड़ी क्या जाने, ये बीड़ी तो यहाँ की है. All the things were started, we started saying all these studies has done from India about the बीड़ी smoking and the lung disease. So burning of biomass fuel is another thing. I will not bore you the epidemiology. More than 3 billion people are using biomass fuel still in India. About 50 to 60% of our population is still using biomass fuel for cooking, heating, and so many things. So, and this is a very common, if you go to the village side, you can see this common scene that kanda hai, uple hai, lakdi hai, crop residue hai. Even these things have been implicated in recent studies to causation of the COPD. And we wrote an editorial, I think, Indian Journal of Tuberculosis, Indian Journal of Chest Disease, Chronic Obstructive Pulmonary Disease in non-smoker. I think Huda is not there. Huda is one of the worker with me, and Harsita. So we said that in India, if you talk of Western figures, 80% of the smoking is COPD is because of the smoking. But in India, various studies has focused that around 40 to 50% only are smoker. It means there are many more factors which I have just enumerated. That risk factors, there are many more, as Madam said in his lecture, badly treated tuberculosis even can lead to COPD, what is known, new name has TOPD or COPD-I. With all these newer guidelines they are trying to, but this is one of the outdoor air pollution, pulmonary tuberculosis and COPD. So, various etiotypes. I was talking to you that initially it was known as COPD due to infections, but in India we call it as TOPD. So what is my take-home message? I come to end of my presentation. My talk was what are the epidemiology and what are the risk factors. So you must have understood by now it's a major cause of chronic morbidity and mortality throughout the world, including our country. And tobacco smoking and exposure to biomass fuel and ambient air pollution as well as indoor air pollution. All the three are very important risk factor for development of COPD. With these few words, I would like to end my lecture. And for the PGs especially, I say that I have my own, many of the PGs used to see it. History taking, people are forgetting how to take history. It reminds me I visited one of the minister when he was ill in some of the big hospital. And I was called, that time I was in Safai as a director, so he called me because he was under me treatment. I asked PG who was at that time, I asked what is the diagnosis? He said, sir, case of bronchial asthma. हमने bronchial asthma है. I am treating this patient for last 25 years as a COPD. And you are saying bronchial asthma? Sir, he is a non-smoker. मैंने क्या कह रहे हो यार? मैं नाम नहीं लूँगा इंस्टीट्यूट का. मैंने कहा भाई इनकी सिगरेट तो मैंने छुड़वाई थी. 40 साल इन्होंने सिगरेट पिया था. So what I am trying to say, history, this art is being forgotten. So that's why I put history, physical, everything. This is auscultation. Auscultation भी लोग भूलते चले जा रहे हैं. आला नहीं लगाते. मरीज का तो लगा लो साहब. आपने लगाया नहीं. आप समझते हो कि CT और एक्सरा देख के सब डायग्नोस कर लोगे? Not possible. So please, I have all the lectures. Especially I put these lectures. Then we have X-ray. One of the lecture I was taking in Iran, we created a YouTube and more than 3 lakhs people have seen. And then lately what you see that I presented this book to Vice Chancellor of this great university. And this is in 2 volume, and what I taught in last 40 years, I must say, I have tried to put in the book. That what Sonia was saying to me, कि सर मैंने भी आपका क्लास अटेंड किया था जब आप एक्सरे पढ़ाते थे उस दौरान. So हमने कहा वही एक्सरे सब इसके अंदर है. So it is in 2 volume and it's quite exhaustive book. And just I wanted to say that I want to end my lecture by saying हम लोगों की सबकी शाम हो रही लगभग. आगे लोग जो बैठे हुए हैं हम लोगों की शाम हो चुकी है हैं. It time is for younger to keep you young. Please remember this, which is said by nothing no more less than Henry Ford, that anyone who keeps learning stays young. So और किसी चीज़ के लिए पढ़ो ना पढ़ो हैं वेद जवान रहने के लिए पढ़ते रहो. With this, once again, I thank you, Dr. Ved, for really inviting me, and he always invite me whenever he does any function. And he also knows that if I am in the Lucknow, if I am free, I will definitely, although today was a flight, but he said, sir, I will do it in the morning, so please come for some time and then go. With this, thank you very much, Ved, and my best wishes to all of you. And I'll just end my lecture here. If you have any question, I'd love to answer, provided I can answer. आजकल.
Thank you, sir. It's always a delight to listen to your words of wisdom. And as sir, you have pointed out in one of your slides, the mortality in China is actually reducing, but in India it's actually showing an upward trend. Probably it is a wake-up call for all of us, all of pulmonologists. Any questions we can take from audience?
So the Japanese proverb was so upright, and my great teacher is Dr. Rajendra Prasad, and like I used to hear it in KGMC when I was a student here, that there are 3 things which are there in a lecture. One is the overview, the second is the detail, and the third is thought provocation, that you should go with a thought. And these are all those things which are here whenever Dr. Rajendra Prasad speaks up. Sir is so marvelous that it gives you the overview of the subject. It gives you the minutiae too, and then it is thought-provoking that you can go home, think about it, and have your own research questions, have your own publications. Thank you so very much, sir.
Thank you, thank you, thank you. भाई ये मेरा लैपटॉप निकाल देना यार.
Thank you, sir, for the wonderful session. Now, I would like to invite Dr. Ved Prakash, sir, to come on the stage and felicitate our speaker, Professor Rajendra Prasad, sir. Now, I'd like to invite chairpersons on stage and get felicitated. Dr. A.K. Singh, sir. Dr. Rachi Sharma, sir. Dr. Vipul Prakash, sir. Dr. Rajneesh Srivastav, sir. Moving ahead with our next session, I would like to invite the chairpersons for our next session. Dr. Amrish Kumar, sir, Professor and Head, Vascular Surgery, KGMU. Dr. Anurag Rai, sir, Associate Professor, Thoracic Surgery, KGMU. Dr. Amit Chaudhary, sir, Assistant Professor, Vascular Surgery, KGMU. Dr. Shalin Kumar, sir, Professor and Head, Thoracic Surgery, KGMU.
I would like to request Dr. Rahul Chandula sir for his presentation. Currently, sir was founder of Delhi Heart and Lung Institute, and he's senior consultant cardiac surgery and program director heart lung transplant at Global Hospital Chennai and Care Hospitals. Sir has been trained at Heart Lung Transplantation and Medical Assist Devices Fellowship, University of Alberta, Canada, and Clinical Fellow in Cardiovascular Surgery, Heart Transplantation, and VATS, Toronto General Hospital, Toronto, Canada. Sir has vast experience in lung and heart transplantation. I will request Sir for presentation.
good morning, everybody. First of all, I would like to thank Dr. Ved and the team, and we have very esteemed eminent pulmonologists, cardiac surgeons, vascular surgeons here. Feel really honored to be presenting today on the topic of our interest, which is COPD. Does lung transplant has any role in end-stage COPD? I'm Dr. Rahul Chandola. I'm a cardiothoracic surgeon, and my specialization is all complex cardiac surgeries and thoracic surgeries. Heart and lung transplant is the special area of interest that I have. So we are currently, we are a group of around 50 people, including cardiac surgeons, thoracic surgeons, then cardiac anesthesia team, then we have a transplant pulmonologist in our team, and then the entire rehabilitation team with the nurses, perfusionists, it's a team of around 50 people. The idea is to give the entire set of gamut of heart and lung solutions, right from bypass operation to valve replacements, aortic surgeries, then thoracic operations, thoracic surgeries, and then heart transplant, lung transplant, ECMOs, LVADs. So right from the basic heart and lung solutions to complex procedures like heart and lung transplants. We are located at Saket PSRI Hospital, Delhi. And the end-stage lung disease is something, where the lung transplant has really got a role. And in certain cases, lung transplant is the only definitive treatment in patients, with end-stage lung diseases like IPF, COPD, cystic fibrosis. Patients, recently, a lot of patients with COVID had end-stage lung involvement. And, many of these patients were candidates for lung transplant. Unfortunately, with the COVID, what happened was the number of donations also went down because of the COVID situation, and hence there were not enough lungs available for transplantation. The lung transplant also did not have that favorable outcomes in the COVID patients. The reason is because COVID was more of a, it was not an isolated lung issue. There were other organs also involved at the same time. But then for young patients who got isolated lung involvement, end-stage lung involvement, lung transplantation really saved many lives. IPF is one of the common indications where lung transplantation is done. In the West, it's a very different clinical scenario in our country. In the West, the IPF accounts for almost 45 to 50% of the patients who undergo lung transplant. And rest 40-45% patients are the COPD patients, and cystic fibrosis forms around 15 to 20% of these patients. So, but then in our country, most of the patients who undergo lung transplantation, the primary indication is IPF or ILDs. And unfortunately, very small proportion of patients with COPD get referred for lung transplantation. The reasons could be many, but I guess, in our population, in our country, more elderly patients are having COPD as opposed to the West, where alpha-1 antitrypsin is also quite prevalent, and, that forms major indication for lung transplantation. And as a result, patients are more aged, and they are generally, in their late 60s and 70s when lung transplantation is really not an option. So, with the recent advancement of the pharmacological treatment in end-stage lung disease, and I think I would probably know the least about this, but just to brush up the things, with the introduction of pirfenidone and nintedanib, things have really changed. Although not particularly for IPF, but in other ILDs, it has certainly got a role. IPF, I'm not sure whether they really help delay the advancement of fibrosis, but these have really made some change in the outlook of patients who have got ILDs. Pirfenidone has antifibrotic and anti-inflammatory properties, and it is proved to reduce the decline of FVC and 6-minute walk test with a 43% reduction of IPF progression or death. Nintedanib, again, this has also been found to have the FVC, to reduce the FVC decline. It also prevented exacerbations of IPF and maintained quality of life in phase 2 studies, even in patients who have got mild to moderate disease, even though no survival benefit was noted. Anti-reflux treatment, it's very common in patients with IPF. Generally, 88% of the patients, need some kind of treatment for GE reflux, in patients undergoing lung transplantation. I'll just skip this slide here. Pulmonary rehabilitation is one such thing which is quite underrated in our country, but this is something of immense value, and especially in patients with end-stage lung disease, where these patients are so debilitated. Some of these patients are on high-flow oxygen. They are debilitated, even get short of breath while talking. And they are generally wheelchair-bound, have not been able to do their day-to-day activities even. These patients, what we have seen is when they present to us for lung transplantation, we generally give 4 to 6 weeks minimum of rehabilitation to these patients, get them enrolled into the rehab program, and then our team focuses very diligently on the respiratory muscles, the small and large muscles of the limbs, the diaphragmatic muscle, and the spirometry, and ultimately, these patients, in 4 to 5 weeks' time, they get to a point where, they're at the time of presentation, their 6-minute walk distance is barely 100 meters. And when they finish that rehab, 4 to 6 weeks of rehab, it's amazing to see these patients with the 6-minute walk distance, going up to 300 meters, 350 meters even. And that's the time where lung transplant becomes a possibility in these patients. Generally, it is a well-known fact, patients with 6-minute walk distance less than 200 meters, they don't have that favorable outcome, if they undergo transplant. But, if they have 6-minute walk distance, which is more than 300 meters, these patients have a favorable outcome. And hence, rehabilitation is so important and integral for any end-stage lung disease or transplant program. So, as I said, it has been proven to be an effective treatment for IPF patients, providing an associated 75% reduced death risk after lung transplantation. And hence the timely referral to a transplant center is important. This is the slide that says exactly what I was talking about. In the West, as we can see, the percentage of patients who present for lung transplantation, the major indication is either COPD or COPD or cystic fibrosis or IPF. In our country, this probably is just IPF. We have very less patients coming for transplant with underlying cystic fibrosis or COPD. Majority, I would say probably 95% of the patients have IPF as the indication for lung transplantation. So I'll just skip this. The history is really interesting. So 1963 was the time when lung transplantation was first introduced by Dr. Hardy. And after that, there were almost 40 failed attempts, till 1983, when the first successful single lung transplantation was done by Dr. Cooper at University of Toronto. And, this is the same hospital, same program that did the first double lung transplant also in 1984. and the same hospital that again performed the first combined heart and lung transplant. So they really have been pioneers in lung transplantation, in the world. Now this is the busiest lung transplantation program in the world now. They do around 180 to 200 lung transplants in a year, which is remarkable. Every second day, they have a lung transplantation going on there. So, and I was fortunate enough to have been trained there, spent almost 5 years in that program. The option of lung transplantation obviously is an option for patients with irreversible lung disease, end-stage lung disease, but it's not for everybody, certainly not for patients when they actually are lying on the ventilator, and really debilitated with multi-organ involvement. That's not where the lung transplant should be considered, but much before that. And it is clearly limited by the organ availability. For patients, where it is indicated, it can do wonders. Now in current era, the 1 year survival is as high as 92-93%, with 5 year survivals coming close to 55 to 60%, which is a good outcomes for a patient who has got end stage lung disease and is not expected to survive beyond a couple of months. The indications, as I said, obstructive lung disease, restrictive lung diseases. Now, today's COPD, World COPD Day, so it's important to talk lung transplantation in context of COPD. COPD is one indication where the outcomes of lung transplantation are phenomenal. Some centers even report up to 97-98% 1 year survival in patients with COPD, and it improves quality of life. At the same time, the patients, especially the patients who are having ICU admissions because of the COPD exacerbations, these are the patients who must be referred for lung transplantation, because as we all know, the patients who are admitted with COPD exacerbation and are found to have a PCO2 of more than 50 in that admission, they have a 1 year mortality of rate as high as 43%. This is really surprising, but this is true. And hence, these patients are the ones, who should be referred for lung transplant timely, because as I said, the lung transplant outcomes in COPD are really phenomenal. So this patient who had a chance of dying almost 43% in 1 year, now, he has a survival outcome of more than 97-98% at the end of 1 year, and will probably go on to survive another 8-10 years with good quality of life. So it's very important to understand what patients need to be referred for lung transplantation and what COPD patients should be referred for lung transplant. So here there's an important slide here that talks about what should be the timing of referral for patients with COPD. So when the disease is advanced, where patient is not a candidate for LVRS, lung volume reduction surgery, when the board index is around 5 to 6, the PCO2 is more than 50 millimeters of mercury, or PO2 is less than 60 millimeters of mercury on room air, and FEV1 is less than 25%. This is the time when COPD patients should be referred. They may not be listed for transplant at that time, but at least a transplant program should be seen by the patient, so that a patient can be well induced into the transplant program in time. And when should the patient be listed for transplant? When should a COPD patient be listed for transplant? So this is a patient where the board index beyond 7, and at least one of the following conditions, like if there is an acute exacerbation with hypercapnia, or if 3 or more severe exacerbations in the last 1 year, or patients with PAH, the pulmonary arterial hypertension is already ensued, or if the FEV1 is down less than 20% or DLCO is less than 20%. These are the patients, they should be immediately listed for lung transplantation because their chances of dying in 1 year are really, really high. And as I mentioned, these patients with acute exacerbations with PCO2 more than 50 have a very high mortality rate. Hence, they should be referred for lung transplantation at this stage. Now, what happens, when a patient is referred for a lung transplant to a transplant team? What we do is we do the preoperative assessment and see whether the patient is fit for transplant or not. So all the routine investigations that are done in cardiac surgery, before any vascular or cardiac surgery, they are done. And in addition, we also do the imaging tests. We do the CT scan of the chest. We do lung perfusion scans to see which lung is affected most. So in case patient requires a single lung transplant, the most affected lung should be taken out. We also do echocardiogram to see the function of the right ventricle especially, and the PA pressures, because that has implications. If the patient has got very high PA pressures, then obviously he needs a double lung transplant. If the PA pressures are low, then in that case, even a single lung transplant would be good enough. Also, the amount of RV dysfunction also decides the prognosis of patient. If the patient has got significant RV dysfunction, so obviously he will take a much longer time in the ICU, and prognosis will be relatively not as good as the patient with normal RV function. So all these tests are done, and once the preoperative assessment is done and patient is found eligible for lung transplant, then he is listed with NOTO. The NOTO is a National Organ and Tissue Transplant Organization, and it's a very well-meaning organization that maintains the list of the recipients from across the hospitals, and it also manages the donor list, and effectively matches the recipients to the donors and gives alerts to the different hospitals based on their matching status. So NOTO is a government organization, obviously, and is a very, very well managed organization. What is the ideal lung donor? So once we have identified that this recipient is eligible for lung transplant, he is listed with the NOTO, and then we wait for a suitable organ donor. So any organ donor which is identified in any hospital, say if the donor is identified here in KGMC. So what we'll do is, Dr. Ved Prakash has the neuro team and the respiratory team has identified a brain dead donor here in the ICU. So all they need to do is they need to notify the NOTO, and that's it. The rest of the things are managed by the NOTO. Their coordinator will speak to the family in addition to the physician, speaking to the family. And if the family agrees, so there has been a study that says, we used to think before that, probably in South, in Chennai, in South, in Tamil Nadu, organ awareness is better as opposed to the North. But there was a study done by Mohan Foundation, and they did this study in different cities like in Chennai, Bangalore, Pune, in Jalandhar, and Delhi. And what they found is when the brain dead donor patients' families spoken to, by a transplant coordinator, and they are told and made aware of the importance of organ donation. That their yes can actually make 8 people live. Like give life to 8 people, and can give hope to many other people, who want different types of tissues, be it cornea, could be skin, could be any other tissue element, So then the conversion rate is almost 65 to 70%. and regardless of which city they were spoken to, like, so in Chennai, in Delhi, in Pune, or in Jalandhar, you know, the response rate was almost similar, you know. And more often than not, it is my experience, you know, that more than educated people, it is the people from the remote villages, you know, who are easily convinced about the importance of organ donation. So education probably is not very important. Awareness is important. And the other thing which is important is, you know, a trained transplant coordinator or a physician, you know, when they speak to the patient's family, generally that leads to the conversion. And it's about, you know, how we convey to the patient's family about the importance of organ donation. So this is the ideal lung donor. You know, what is an ideal lung donor? You know, the patient has got a PF ratio, the PO2 by FiO2 ratio, which is more than 350, and the donor should not have a history of smoking. The chest X-ray should be clear. The number of days on ventilator should be less than 4 to 5. Patient's sputum should not reveal any infection. The bronchoscopy should be clear. Patient should not have any visible food particles in the airways. There should not be any airway inflammation or infection. And if the expected ischemic time is less than 6 to 8 hours, you know, this is an ideal lung donor. And if these criteria are met, these donors are generally deemed fit for transplantation. So this is how the organs are being transported, and as you can see, so this is the card that we carry. So we carry this the box there with the ice slush in it. There are a lot of other paraphernalia here with the Perfidex solution, the custodial solution. All these solutions that are used to preserve the lung and the heart are carried in this box. And then there are instruments, you know, that we carry. Now this thing is going to be obsolete in coming times, you know, because now the new concept is coming up about preservation at 10 degrees, you know. So this, you know, this is 0 degrees, or probably, you know, less than 4 degrees, you know. When we put the organs on ice slush, the temperature is anywhere between 0 to 4 degrees. But now the studies are coming up that are saying that organs are best preserved at 10 degrees and not 0 to 4 degrees. And hence, there are companies who are coming up with 10-degree coolers, you know, so where the organ can be preserved at 10 degrees. And surprisingly, now the things are very clear that lungs can be stored even up to 24 hours in these 10-degree coolers, you know, as opposed to being kept in the ice slush, where the ischemic time was, maximum ischemic time was up to 6 to 8 hours, you know. So now they can be stored even up to 24 hours. So this is really remarkable, because now you can get the lungs in the 10-degree cooler from anywhere in the world. You go to any continent and bring the lung from back in the 10-degree cooler, and this will be really remarkable. So the pool of organs will increase, and the second thing is the transplant will become elective operation rather than being an emergency, you know, that used to be, like, you know, mostly, you know, we do transplants in the night time. But now, you know, you can easily send a team there, put that in the 10-degree cooler, bring it back, keep it till morning, and the entire team assembles in the morning. So that's how things will change in the transplant scenario now. So these are the lungs, you know, as you can see from one of the donors that we got from CMC Vellore, and these lungs are looking very pink. You know, these are the lungs of a 21-year-old guy who had been declared brain dead there, and you can see the lungs look so pink, and these lungs were quite matching lungs for our recipient, and this recipient was then. So we bring the lungs back in the preservative solution. And then once they are in the recipient hospital, we do the back table dissection and dissect out the pulmonary artery, pulmonary vein, and the bronchial cuff. And these are later transplanted into the recipient. So single lung transplant, the lung transplant can be single lung or double lung transplant. Single lung transplant can be done to optimize the available donors, and as I said, it can be offered to patients with COPD or ILD where the PA pressures are normal or they are mildly raised. In patients where the PA pressures are really high, we cannot offer single lung transplant. They have to undergo double lung transplant. So this is the patient who got that single lung transplant. You can see the posterior lateral incision, but we can also do that through an anterolateral incision. An example is this lady, 29-year-old lady, was diagnosed with scleroderma and presented with very poor PFTs, and she was on 5 liters per minute of oxygen at the time of presentation and was barely able to do the daily activities. This is her CT scan, as you can see, typical honeycombing hair, really bad lungs. And this patient was then listed with NOTO, and she was lucky enough, she got that organ in 3 weeks' time, again from another hospital in Chennai. The ischemic time was around 4.5 hours, and these were the lungs that I showed were the lungs that were given to this lady. So unfortunately, this lady was very short, around 4 feet 10 inches, and as someone was mentioning just now, so matching of the recipient with the donor is very important. So for the IPF patients, for the fibrotic disease patients, their chest cavities are really small. So we have to look for the donor that is at least 5 centimeters shorter than the recipient, so that the lungs can fit in the small chest cavity. Unfortunately, these lungs were quite big. The recipient was around 5 feet 5 inches. He was a male, and obviously we figured out that these lungs cannot fit in the small chest cavity of that lady. So we had to size reduce these lungs. We did the back table lobectomy for this patient, and ultimately this patient got the lung transplant. Now, double lung transplant, where the double lung transplant should be done? It should be done for patients with underlying suppurative lung disease, like a patient having bronchiectasis or cystic fibrosis, because if we do a single lung in these patients, the other infected lung can make the transplanted lung can transfer the infection there. So underlying suppurative lung disease, we should always do a double lung transplant and never a single lung transplant in that case. The other thing is the patients with high PA pressure should undergo double lung transplant. Patients with RV dysfunction, they should undergo double lung transplant. So this is how the double lung transplant is being done here. You can see. So this this was the time when cardiopulmonary bypass was used to do a double lung transplant in most of the cases. But now the things are changing, and rather than cardiopulmonary bypass, we are utilizing ECMO. And we are using ECMO routinely in our lung transplant patients, because using ECMO obviates the need for the heparin. For cardiopulmonary bypass, we have to give patients high doses of heparin. That leads to more bleeding issues. At the same time, patient, the systemic inflammatory response is much more in cardiopulmonary bypass as opposed to a ECMO. So now most of the lung transplants we do are on ECMO, and these are mostly elective ECMOs, intraoperatively that we use. You can see this cannula in the aorta and these two cannula in the SVC and IVC, and this side the diseased lung has been taken out, and this is the transplanted lung on this side. Then we go to the other side, take out the diseased lung on the other side, and do a sequential double lung transplant. So this is called sequential double lung transplant, as opposed to the en bloc transplant, which was done more than 2 or 3 decades ago, where both the lungs along with the trachea used to be transplanted. Unfortunately, with the tracheal anastomosis, the chances of dehiscence were so high that procedure was abandoned, and now we do sequential lung transplantation, where we anastomose the main stem bronchus of the recipient and donor and don't touch the trachea at all. And that has led to much better outcomes in lung transplantation. So this is the incision that we use for our double lung transplant. You can see this is the clamshell incision, goes from one axilla up to another axilla, and that just exposes both the lungs along with the heart. So this is that patient, you know, the short lady that I mentioned, 4 feet 10 inches. She got the organ of a relatively, ideally she should have got a smaller lung, but you know, she was very sick, required the organ, so we had to do the size reduction in that donor to fit in those lungs into her chest cavity. This is another heart lung block, as you can see. These lungs are not looking that great as the previous lung. You can see there are a lot of, so these are the lungs of a smoker, but this was a smoker like 5-pack years, that was the history. Generally up to 10-pack years, so lung donor criteria also have modified in order to increase the pool of the lung donors. Now the criteria have become little relaxed, so you can accept the donors, up to 10-pack years history of smoking, as long as their PF ratio is more than 300 to 350. So this patient's PF ratio was good, even though the lungs were not looking good, but our recipient was deteriorating, so we had to take these lungs, and the patient was given the lung transplant. This is the patient who got that lung transplant, Afghani national, young guy, 24 years old guy who got that double lung transplant. This was the patient with COPD. This is the only COPD I have transplanted so far. Most of the patients that we have here in the country, as I said, most of the patients that we transplant, they are patients with underlying IPF or sometimes patients with bronchiectasis. So this is the patient who got that minimally invasive lung transplantation. This is another professor who got that lung transplantation. He was around 46, 47 years of age. Survived almost 6.5 years after double lung transplantation. He got that clad, the BOS that generally the lung transplant patients, many of these lung transplant patients develop after 5-6 years of transplant. This is a patient, who had 2 hospitalizations with very high PCO2, going more than 60, 65 in each hospitalization. And that this patient had a board index of around 7. And this patient was considered for transplantation. And he's got very good quality of life after transplant. Even has participated in 2 of the marathons, in Chennai. So this is another thing which is new in the lung transplantation, the ex vivo lung perfusion. So the problem with the lung transplantation is, number one is the scarcity of the organs, and whatever organs come, they are not the perfect organs. So I'll give you an example. The donor acceptability with a kidney transplant is around 90 to 95%. So what that means is, of 100 donors, kidney donors that come to the nephrologist or the renal transplant surgeon, 90 to 95% of those donors will be accepted. For liver, that ratio is somewhere around 80 to 85%. For the heart, it is around 35 to 40%. For lungs, the donor acceptability is only around 15 to 20%. So what that means is, for 10 donors that come in the pool, only 1 to 2 will be good enough to be transplanted. Because what happens is, lung is an organ which is exposed to the outside environment. So when and generally, these patients are on ventilator, these brain dead patients are on ventilator. They are on ventilator for more than 2-3 days. Obviously, the barotrauma is an issue. Second thing is, at the time of arrest, many of these patients would have had aspiration pneumonitis, aspiration and leading to aspiration pneumonitis. Third thing is the competing interest of the kidney transplant and the lung transplant. So what happens when the patient is in the ICU, this donor will be given lots and lots of fluids by the renal team because they want to flush the kidneys, right? And that flushing of the kidneys actually leads to a lot of lung volume overload, and that makes the lungs boggy, you know, and these lungs are no more good for the transplant. So unfortunately, the donor acceptance is still 15 to 20%. To increase that pool to make these lungs healthy again, this is the new technology that has evolved called ex vivo lung perfusion. So what that is, the lungs which are taken out from the donor are kept inside this dome, and these lungs are being perfused by osmotically active solution, and what that happens is, you know, because it's oncotic pressure is high, it draws the blood water out of those boggy lungs and improves their PF ratio, their PO2. You know, when their lungs are perfused with this solution for 3 to 4 hours, and at the same time, there are antioxidant properties also in this solution. Generally, we use Teen solution, and this is a specialized solution which dries out the lungs at the same time, so it's got antioxidant properties, decreases the systemic inflammatory response also here. And in one of the study, it has been found the donor pools in Toronto General Hospital, the acceptability was 15-20%. But since the time this is utilized there, the acceptability has gone higher up to, you know, 45 to 50%. So this is something remarkable. So many of those lungs, you know, hundreds of those lungs, which were initially found unsuitable for lung transplant, they are now being transplanted. So this is one very important technology that has led to utilization of the marginal lungs also. Another thing, you know, this is organ care, lung in a box, you know, this is just like a box. You take this entire assembly to the donor hospital and then put those lungs into this box here and bring it back to the recipient hospital. And these lungs can be in this box for 8, 10, 12 hours, you know, and that also increases the time duration, the ischemic time, you know, that is acceptable. So these are certain advancements in the field of lung transplantation that has happened in recent. So this is the Transmedics lung in a box, you know. So we even carried it. So I was in Edmonton, Alberta, and from there we even went up to California. You know, almost like 8 to 10 hours of journey. In the night, you go there, take out the lung, put that in this thing, and then forget about it for next 8 to 10 hours, you know. You're in no rush, no hurry, you know. Lungs are well perfused during that time. You come back to the recipient hospital, your hospital, and then do the transplant as an elective procedure. So this is something new in the field of lung transplantation. And this is the double lung transplant patient we did recently on ECMO support. This patient had, been in and out of ICU, was on BiPAP at the time of transplantation, and actually was saved by putting in an ECMO because his gases were really bad and we were about to intubate him. So we put him on ECMO, and fortunately for him, you know, he got organ in time and was then he received a double lung transplantation. So with that, I'll just end my presentation. Thank you so much for the patient listening.
Thank you, Dr. Chandola, for your nice, deliberation. So before giving to the audience, I have one clarification. How many times you get donor from the trauma, means traumatic patients?
Yeah. So most of these patients are brain dead patients. You know, these are the patients who get road traffic accident, and then, you know, they were declared brain dead after that. Small percentage of patients are the ones who have got stroke and then are declared brain dead. But most of these are, you know, these young guys who are riding donors in a month, how many transplants can you do? You compare that to the program in Tamil Nadu, where they get around 18 to 20 donations in a month, you know. So at least you can do 2 or 3 transplants there, right? So now here the things have really improved in last 7-8 months. Our PM actually spoke about importance of organ donation. He spoke about that in Man Ki Baat, you know, for almost 15 minutes, you know, he spoke continuously, you know. And after that, things have improved. We are seeing close to 15 to 20 donations in North now. And this is the time which is perfect for the organ transplant, brain dead cadaver organ transplantation in the North, you know. So in times to come, you know, North will certainly 100% it will beat South in heart and lung transplants, because the organ donations are happening now and they are on a rise. Like every 6 months you see there is a drastic difference in the number of donations happening. So, yeah.
Okay, any question for audience here?
Right. Right.
Is there any scope for JFL bulb that is approved by FDA?
For
JFL bulbs that has been approved by FDA. FDA has approved some JFL bulb for these COPD patients.
yeah.
In the literature, I have read they are doing better than
The LVR. Yeah.
balloon resistance surgery, another thing.
Right. So yes, I mean, there are certain indications for the patients who undergo LVRS, you know, and obviously these are the patients, you know, who are not candidates for LVRS. You know, obviously they are so sick, they are on high flow oxygen, they are debilitated, they are seeing these exacerbations in the ICU. So not fit for LVRS, probably LVRS is going to do harm to them. The criteria that I mentioned, you know, board index more than 7, 2 or 3 exacerbations in last 12 months. So these are the candidates. No, I'm not aware about that, sir. Actually, I'm not surgeon, so obviously, you know, my knowledge about that would be very limited. But I think Dr. Ved Prakash would know.
Actually, sir, in the cases of hyperpenetrated lungs, in emphysematous lungs, when we need to reduce the volume, one is surgery, another is valves which are available and we introduce through bronchoscope and collapse the certain segments, and that is also acting like a volume reduction. So I think you are talking about that. Yeah.
Yeah. Right.
Yeah, that was the topic today Dr. BP Singh was talking about, and he delivered about the biologicals, use of biologicals in the management of COPD. So that is the another area. And for this lung reduction surgeries, one is surgery and another, there are many other devices also. There are spigots. We put the spigot in the certain already marked areas where the exchange is, very much limited and that is compromised. So in these segments, we put a spigot and seal with the sealant glue, and that is also there. And so many devices are there. So that is also getting popularized, and we are also initiating it at our center itself. So thank you, sir.
So there is chance of, I think, ECMO or ventilator dependence, because many patients are ventilated for,
I think, for
Right.
days, on the weeks.
Right.
How they respond after transplantation?
Yeah. So importantly, one subset of patients which benefit remarkably is the young patients. The young patients with isolated lung involvement. So rest of the organ function should be perfectly fine. And these patients, if there is a provision that these patients can have some form of rehabilitation before the transplant, even if they are on ECMO. Like now the ECMO is also advanced in cases of lung transplant, because now what we are preferring is this single cannula, rather than the two cannulae in the jugular and the femoral. So single cannula in the IJV, it's a multi-port cannula. With that, you can mobilize the patient, and you can have the awake ECMO also. So awake ECMO is something which is getting very popular now. So these patients, rather than putting them on ventilator, if you can put them on ECMO and ensure that these patients are undergoing rehabilitation of some sort, and that is facilitated with the use of this multi-port single cannula. These patients can be made to sit on the, they can be dangled on the bed, they can even walk, in the ward, and entire rehabilitation can be done with these patients. And generally, younger age group patients, they, with the single organ involvement, they do well after lung transplant. Some of the studies have even said that, there's no difference in the outcomes in patients, who received preoperative ECMO as opposed to those who just came electively for the lung transplant. Yeah.
Thank you. Thank you. Any question from the audience?
Thank you, sir, for such an informative session. Now I invite Professor Ved Prakash, sir, to come on the stage and facilitate our speaker, Dr. Rahul Chandola, sir. Now I invite our chairpersons to come on the stage and get felicitated. Dr. Shailin Kumar, sir. Dr. Amrish Kumar, sir. Dr. Amit Chaudhary, sir. Dr. Anurag Rai, sir. Moving ahead with our next session, I would like to invite the chairperson for next session, Dr. K.B. Gupta, Professor and Head Pulmonary Medicine, Era Medical College. Dr. Ajay Kumar Verma, sir, Professor, Respiratory Medicine, KGMU. Dr. Anand Kumar Srivastav, sir, Additional Professor, Respiratory Medicine, KGMU. Dr. Ankit Kumar, sir, Assistant Professor, Respiratory Medicine, KGMU. Dr. Sachin Kumar, sir, Assistant Professor, PCCM Department, KGMU.
Now, good afternoon, everyone. First of all, my sincere thank. कोई बात नहीं कर लीजिए. Just we start. कर लीजिए. You take your own time. First of all, my thanks to Professor Ved Prakash for just giving me this opportunity to be here on this World COPD Day and COPD Update 2023. Very nicely arranged program and good academic also. Topics are very recent topics, and also the speakers are very, you can say, eminent personalities in the field of the pulmonary medicine. Now, the talk is on the Gold Guidelines 2024. Now, this is actually a very remarkable to Dr. Kushwaha Sahab, because I think these guidelines are released only about 1 week back. So he has prepared this topic within a short span of time, and really it's a very credit to him for covering this topic on what are the changes have been made in the Goal 2024. Now, Goal guidelines are the guidelines which we follow for the COPD management, published every year by the group of the experts globally. And so many changes have been made. But you see, this time, though I have really not gone through in detail the guidelines till now, because this is, you can say, short span of time. But I came to know that they have covered some topics in the wide range. Like you can say, the PRISM they have covered, you can say the hyperinflation they have covered, then the smoking cessation programs, the chemotherapy or the pharmacology of the smoking cessation also, vaccination topic also, and also about the, you can say, the first time I have heard about the this COPD screening program. It has been included in this part, and this will help, of course, a part of the lung screening program and the ILD also. They've also covered the interstitial lung abnormality, ILA also. So many things I think Dr. Kushwaha has gone through, and he will highlight what key changes have been made in the Goal 2024. So Dr. Kushwaha need no introduction. He's a very eminent pulmonologist and professor of the respiratory medicine in the Department of Respiratory Medicine, the King George Medical University, Lucknow. Or he is very, I can say, thorough academician and very good friend of mine. So I invite Dr. Kushwaha Sahab to please speak.
थैंक यू प्रोफेसर के.वी. गुप्ता सर. सर हमारे टीचर हैं. सबसे पहले मैं प्रोफेसर वेद प्रकाश को धन्यवाद देना चाहूँगा कि काफ़ी प्रेस के लिए एक्टिविटी अभी इससे पहले भी किया उन्होंने वर्ल्ड COPD डे पे, और ये CME भी हो रहा है. तो वेद प्रकाश जी को बहुत बहुत धन्यवाद, पूरे डिपार्टमेंट को धन्यवाद. सो जैसा कि अभी हम लोग देख रहे थे, सुबह से सुन रहे हैं, मीडिया के लिए जब बात कर रहे थे उस समय भी, जो COPD की समस्या है बहुत बड़ी समस्या है, और इसको आप कह सकते हैं टिप ऑफ द आइसबर्ग. जितना हम जानते हैं, जितने लोग को हम रीच कर पा रहे हैं पेशेंट्स को, या जितने लोगों तक हमारी बात पहुंचती है, बहुत कम लोगों तक पहुंचती है. वास्तव में समस्या बहुत बड़ी है. ये कहते हैं अंडर परसिव्ड प्रॉब्लम कह सकते हैं, जो हमारे कंट्री में बहुत ज़्यादा स्मोकिंग प्रिवेलेंट है, हम समझ सकते हैं. तो अभी शायद बहुत ज़्यादा एजुकेट करने की ज़रूरत है, जागरूक करने की ज़रूरत है, और जिससे आप इसमें समझ सकते हैं, जैसे प्रोफेसर प्रसाद सर कह रहे थे कि इसमें ट्रीटमेंट वगैरह सब चीज़ है तो ज़रूर, मगर जिस समय हम उसको ऑफ़र कर रहे हैं उसमें बहुत कुछ करने को नहीं है. और COPD की समस्या तब समझ में आती है जब नाक से ऊपर पानी चला जाता है. तो पेशेंट बहुत लेट इसको रिकॉग्नाइज करता है, प्रेजेंट करता है. तो इसमें ज़्यादा रोल प्रिवेंशन का है. और अब जो लेटेस्ट गोल्ड गाइडलाइन अपडेट है, उसने इसको एड्रेस भी किया है कि हाउ वी शुड रिकॉग्नाइज एज अर्ली एज पॉसिबल, सो दैट अर्ली ट्रीटमेंट कैन बी ऑफर्ड. So this is the you can say level of evidence. Everybody of us know that level A evidence, level B evidence, level C and D. So ये ज़माना भी evidence based medicine का है, और हर साल जो COPD गोल्ड गाइडलाइन का अपडेट आता है, और नए रेफरेंसेस के साथ में नए लिटरेचर जो एविडेंसेस हैं उसको इनकॉर्पोरेट करते हुए हर साल इसका अपडेट आता है. इस साल भी 148 न्यू रेफरेंसेस हैव बीन एडेड टू द लेटेस्ट गोल्ड अपडेट. एंड यू कैन सी डेफिनीशन में कोई चेंज नहीं है, डेफिनीशन ऑलमोस्ट सेम है बिल्कुल। और जैसे अभी हम लोग बात कर रहे थे नॉन स्मोकर एरिया भी, वो जैसे भी प्रसाद सर ने कहा 40% COPD उस सेगमेंट में जो नॉन स्मोकिंग सब्जेक्ट्स हैं ड्यू टू मेनी अदर रीजंस, जैसा कि अभी सर ने बताया था। डेफिनेटली वेस्टर्न पॉपुलेशन में स्मोकिंग इज़ द मेन रीज़न, बट इन आवर सेटअप ऑलमोस्ट 40% पेशेंट्स दे आर इन इवन इन द नॉन स्मोकर एरिया। दिस ग्राफ सोज दैट जैसे लंग का जैसे जो इवन बहुत ही पहले से पता लग जाएगा, जैसे कि अगर जैसे ये एज इस पे आप देखेंगे एज है, और दूसरा लंग डेवलपमेंट। एट द एज ऑफ 25 अप टू 25 years ऑफ लाइफ द लंग अचीव्स ग्रेटेस्ट हाईएस्ट लेवल ऑफ डेवलपमेंट। तो उस दौरान उस पीरियड में अगर कोई इन्फेक्शन या कोई ऐसी बात होती है तो वो इसमें हाईएस्ट लेवल को अचीव नहीं कर पाता। तो कुछ ऐसे भी जो ये भी एक एरिया आप एड्रेस कर रहे हैं कि जैसे हम लोग हमेशा 40+ की 40 एज के बाद हम कहते हैं COPD, लेकिन इसकी शुरुआत काफ़ी पहले से हो सकती है। तो अगर किसी का लंग फुल डेवलपमेंट लेवल पे नहीं आता है तो दैट विल बी आल्सो ए रिस्क ग्रुप। Then key changes in 24. So new references have been added, as I told. Information about the prism. अभी सर बता रहे थे KB गुप्ता सर. So what is prism? We know that preserved ratio but impaired spirometry. इसमें क्या है, FEV1 और FVC का रेशियो तो प्रिजर्व रहता है, that is more than 0.7, but FEV1 और FVC ड्रॉप हो जाता है, तो that is less than 80%. So this subset is called as prism, preserved ratio but impaired spirometry. A new section of hyperinflation, जैसा अभी सर ने भी ओपनिंग रिमार्क में दिया था, इसको एड्रेस किया है. In the spirometry section, further clarification about the pre-bronchodilator spirometry also has been addressed. A new section on the screening of COPD in targeted population has been added with information on leveraging lung cancer imaging for COPD screening. देखिए जो COPD पेशेंट होते हैं ये इसी सबसेट में लंग कैंसर की भी पॉसिबिलिटी है. We all should be always watchful. और जो प्रिवेंटिव स्ट्रेटजीज और ये जो जन जागरूकता है इससे लंग कैंसर एरिया को भी एड्रेस करने में मदद मिलेगी. इन द इनिशियल असेसमेंट सेक्शन द पैराग्राफ्स ऑफ ब्लड यूसिनोफिल काउंट हैव बीन अपडेटेड. तो अभी आगे हम दिखाएंगे कि इसका कैसे इस गाइडलाइन में गोल 24 में इसको यूसिनोफिल का कंसेप्ट क्या है, किस सबसेट ऑफ पेशेंट में इसका रोल होगा. इंटरस्टिशियल लंग एबनॉर्मलिटीज आर नाउ कवर्ड. द सेक्शन ऑन स्मोकिंग cessation हैज बीन रिवाइज्ड. Vaccination recommendation for people with COPD have been updated in line with the current guidance of US Center for Disease Control CDC के in line how the vaccination schedule should be. The managing inhaled therapy has been expanded and includes information on patient ability to use delivery system correctly and choice of the inhaler. जैसे हमें पेशेंट की नीड और उसके सुटेबिलिटी से हमें ये सब इनहेलर फाइनल करना है. अपनी तरफ से ये नहीं कह देना कि तुम्हें यही लेना है. किसको DPI सूट करता है, किसको MDI सूट करता है, एंड इवन इन दैट आल्सो मतलब अकॉर्डिंग टू सुटेबिलिटी एंड देयर चॉइसेज यू हैव टू ऑफर. अपनी तरफ से बिल्कुल कंपल नहीं कर देना कि यही करना है. और हर बार उसको ये भी एड्रेस करना है. सपोज हमने MDI लिखा है, हाउ परफेक्टली ही इज़ टेकिंग. MDI इज़ अ वेरी गुड ऑप्शन, बट जो डे टू डे प्रैक्टिस में हम देखते हैं कि मतलब इवन पढ़े लिखे मरीज भी करेक्टली नहीं लेते हैं. तो अगर शुरू में जब हमने प्रेस्क्राइब किया उस समय अगर सही से उसे नहीं समझाया या उसको हर विजिट पे नहीं चेक किया तो उसमें नॉन कंप्लायंस समझ लिए. नॉन कंप्लायंस का मीन्स कि वो ले तो रहा होगा लेकिन ड्रग डिलीवरी टू द टारगेट ऑर्गन लंग्स एडिक्वेट नहीं होगी. कई बार तो वो इनहेल ही नहीं करता है, इनहेल नहीं कर रहा होता, क्लिक हो जाता है. So there is a usual problem. We note that there is a hand-lung coordination problem. So a new section on pharmacotherapies for smoking cessation has been added. About the prism I told, so normal ratio FEV1 FVC का ratio normal होगा लेकिन abnormal spirometry finding जो FVC और FEV1 less than 80% होगा. The prevalence of PRISM in population-based studies ranges from 7.1 to 11% and 10.4% to 11.3% in a selected population of current and former smokers. Associated with both high and low body mass index, तो प्रिज्म इनमें जो अगर BMI ज़्यादा है या कम है दोनों में ये देखा गया है. फीमेल जेंडर में ज़्यादा होगा ओबेसिटी, मल्टी मॉर्बिडिटी, cause of multimorbidity associated with increased risk of cardiopulmonary disease, all cause and cardiovascular mortality, hospitalization and increased risk of developing airways obstruction. प्रिज्म इज नॉट ऑलवेज अ स्टेबल फिनोटाइप. जो प्रिज्म जिसको हम लेबल कर रहे हैं आज की तारीख में, उसका फ्यूचर में इम्प्रूवमेंट साइड में भी जा सकता है या वार्सनिंग साइड में भी जा सकता है. फुल फ्लेज COPD में भी आगे फ्यूचर में डेवलप होने का चांस है. सो 20 to 30% ऑफ प्रिज्म सब्जेक्ट ट्रांजिशन टू ऑब्स्ट्रक्टेड स्पायरोमेट्री ओवर टाइम. प्रेडिक्टर्स ऑफ ट्रांजिशन फ्रॉम प्रिज्म स्पायरोमेट्री टू COPD आर लोअर बेस लाइन FEV1 and FEV1 upon FVC ratio, higher age, current smoking, female gender and a former forced expiratory time in a second assessment. So pre-COPD की बात 2023 में भी की गई थी. तो respiratory symptoms, risk factors and our structural lung lesions, emphysema and our physiological abnormalities including low and normal FEV1, gas trapping, hyperinflation, reduced lung diffusing capacity and our rapid FEV1 decline. Without airflow obstruction, FEV1 upon FVC ratio is more than 0.7 post bronchodilation. Subjects with pre-COPD or PRISM are at risk of developing airflow obstruction over time, but not all of them will do so. Not all individuals with pre-COPD or PRISM will eventually develop fixed airflow obstruction over time, and hence COPD, but they should be considered patients because they already suffer symptoms and have some functional or structural abnormality, and as such they deserve care and treatment. But the challenge अभी current data ऐसा है जो उसके accordingly that there is no evidence on what is the best treatment for these subset of patients. तो अभी गाइडलाइन इस पर अभी साइलेंट है. अभी आगे रिसर्चेज प्रूव करेंगी कि हाउ दिस सबसेट विल बी मैनेज इन फ्यूचर. प्रपोज टैक्सोनॉमी अभी प्रसाद सर ने सुबह मॉर्निंग में बताया कि COPD-G, COPD-D एंड COPD-C. आई थिंक वी आर अवेयर. पहले वाले गाइडलाइन में भी है, 2023 में भी ये सेम चीज़ है. So clinical indicator for considering a diagnosis of COPD. So dyspnea that पहली बात है कि जिसको हम COPD की diagnosis बना रहे हैं उसमें spirometry mandatory है. That is gold standard investigation for also. So dyspnea that is progressive over time and worse with exercise and should be persistent. Recurrent wheeze, chronic cough may be intermittent or may be non-productive. Recurrent lower respiratory tract infection, history of risk factors. टोबैको स्मोक, जैसे अभी प्रसाद सर बता रहे थे, हमें हमेशा सिगरेट स्मोकिंग की बात करते थे, लेकिन हमारे सिनेरियो में बीड़ी भी है, हुक्का, चीलम, गांजा, जितने भी प्रकार इसमें गाइडलाइन में भी लिखा है कि लोकल चीज़ों के हिसाब से भी आपको देखना है कि जो ऑक्यूपेशनल डस्ट, वेपर्स, फ्यूम्स, गैसेस, अदर केमिकल्स, होस्ट फैक्टर्स, genetic factors, developmental abnormality, low birth weight, prematurity, childhood respiratory infection, as we have just discussed. So they are all important. So causes of chronic cough, I will not go in detail. Chronic cough के और भी reason हो सकते हैं. So differential diagnosis, I will not go in detail about this also. We know. So consideration for performing spirometry. So I think I should not go in detail about this also. We all know that how the spirometry should be performed, proper patient selection, then actual spirometry, bronchodilation का bronchodilator देते हैं, उसको मतलब पोस्ट ब्रोंकोडायलेटर FEV1 और वो देखने के लिए इंडिसेस वी एडवाइस, और कब उसको कितने पहले से हम वो करके बुलाते हैं तैयारी से. So this is normal spirometry testing, and this is COPD. We can see FEV1 is less, FVC is less, and the ratio is also shows obstruction. So role of spirometry is for diagnosis, for assessment of severity of airflow obstruction, and for prognostication. And spirometry is also necessary for follow-up assessments, for therapeutic decisions, and for identification of rapid decline over time. So gold grades, we all know, it is same as before: gold 1, gold 2, gold 3 criteria, and gold 4. Mild COPD, this FEV1 more than equal to 80% predicted, moderate 50 to less than 50, more than 50, and less than 80, and severe COPD 30% to 50%, and less than 30 is gold 4 category. And this is a modified MRC dyspnea scale. This questionnaire, patient fills one of the boxes according to his current situation, and it is graded accordingly. This is COPD assessment test. We all know this. Then latest, this gold AB assessment tool. Depending upon the spirometric characteristics, depending upon the MMRC scale, MMRC status, and the history of exacerbation. According to this, we grade the case as A, B, and E categories, depending upon their values. So CT के बाद इस गोल्ड गाइडलाइन में 24 में कही गई है, जो डिफरेंशियल डायग्नोसिस फॉर फ्रीक्वेंट एक्सेसरबेशन विथ एक्सेसिव कॉफ विथ स्पूटम प्रोडक्शन, रेजिंग कंसर्न अबाउट ब्रोंकिएक्टेसिस एंड एटिपिकल. मतलब इसे एक DD डिटेक्ट करने के लिए भी आपको CT की ज़रूरत पड़ेगी. लंग वॉल्यूम रिडक्शन सर्जरी, जैसे अभी डॉक्टर चंडोला सर बता रहे थे, तो उसमें भी डिसीजन मेकिंग के लिए उसका CT की ज़रूरत पड़ेगी. This endobronchial valve therapy may be a therapeutic option for patients if they demonstrate post-bronchodilator FEV1 between 15 to 45% and evidence of hyperinflation. तो अभी जो सर आप पूछ रहे थे वो लंग वॉल्यूम रिडक्शन प्रोसीजर्स के लिए इम्पॉर्टेंट होगा. लंग वॉल्यूम रिडक्शन सर्जरी, एक तो इंडोब्रोंकियल प्रोसीजर्स है, दूसरा है लंग वॉल्यूम रिडक्शन सर्जरी. जो इंडोब्रोंकियल प्रोसीजर है, इंडोस्कोपिक प्रोसीजर है, वो तो ब्रोंकोस्कोप के थ्रू करेंगे. बाकी ओपन लंग रिडक्शन सर्जरी भी होता है. लंग कैंसर स्क्रीनिंग की बात इस गाइडलाइन में कही गई है कि साइमल्टेनियसली इस सबसेट ऑफ पेशेंट में, COPD के पेशेंट्स में, हमें कंटिन्यूसली वॉचफुल रहना है कि कुछ लंग कैंसर हो तो उसे अर्ली पिकअप किया जा सके और उसका अप्रोप्रिएट मैनेजमेंट करा जाए. गोल्स फॉर ट्रीटमेंट ऑफ स्टेबल COPD, हमारा इसमें गोल क्या है? रिड्यूसिंग सिम्टम्स एंड रिड्यूसिंग द रिस्क. मैनेजमेंट ऑफ COPD, तो इसमें इस तरह से ये पूरा चार्ट हम देख सकते हैं. पहले हम अगर अप्रोप्रिएट सिम्टम्स हैं, रिस्क फैक्टर्स है, स्पायरोमेट्री करेंगे, रिपीट स्पायरोमेट्री इन बॉर्डरलाइन केसेस. इसके बाद हम उसको इनिशियल असेसमेंट कैसे करेंगे, जैसे अभी हमने बताया, जैसे ग्रेडिंग करेंगे, FEV1 स्पायरोमेट्री के आधार पर क्या है उसका है, सिम्टम स्कोर क्या है, बाय COPD असेसमेंट टेस्ट एंड बाय MMRC स्केल. सो AB ग्रेडिंग हम करेंगे, हिस्ट्री ऑफ एक्सेसरबेशन विल बी इम्पॉर्टेंट, स्मोकिंग स्टेटस उसका क्या है, एंड इन सम केसेस अल्फा 1 एंटीट्रिप्सिन लेवल हु आर यंगर एज ग्रुप ऑफ पेशेंट, यूजुअली लेस देन 30 years एज, तो उनमें अल्फा 1 एंटीट्रिप्सिन डेफिशिएंसी का केस हो सकता है. एंड अदर कोमॉर्बिडिटीज यू हैव टू कंसीडर. सो इनिशियल मैनेजमेंट, स्मोकिंग सेसेशन, वैक्सीनेशन, अभी सर बता रहे थे, एक्टिव लाइफ स्टाइल एंड एक्सरसाइज सजेशंस, इनिशियल फार्माकोथेरेपी, सेल्फ मैनेजमेंट एजुकेशन, रिस्क फैक्टर टू बी एड्रेस, देन इनहेलर टेक्निक्स जैसा अभी हम डिस्कस कर रहे थे, रिटर्न एक्शन प्लान शुड बी गिवन टू द पेशेंट्स एंड मैनेज कोमॉर्बिडिटीज। तो ये हमने इनिशियल मैनेजमेंट दिया, इसके बाद उसको रिव्यू करेंगे अबाउट द सिम्टम्स, उसका जो स्कोरिंग अभी करेंट स्कोर क्या स्कोर आफ्टर द गिवन अ सेट ऑफ मैनेजमेंट, क्या उसका स्कोर आता है, मतलब सिम्टम स्कोर, एक्सेसरबेशंस कितना कम कर पाए, स्मोकिंग स्टेटस, एक्सपोजर टू अदर रिस्क फैक्टर्स, इनहेलर टेक्निक्स एंड अडियरेंस। एवरी विजिट आपको ये देखना है, और बाकी रिव्यू टाइम में खासतौर से देखना हाउ ही वॉज अडियरेंट टू योर सजेशंस। Physical activity and exercise, need for pulmonary rehabilitation, self-management skills, breathlessness, written action plan, need for oxygen, NIV and lung volume reduction, palliative approaches, vaccination, management of comorbidity, and spirometry at least should be done annually. Guideline कहती है कि annually उसका आप spirometry ज़रूर कराएं. So identify and reduce risk factor. इसका लेवल ऑफ एविडेंस क्या है? स्मोकिंग सिसेशन इंटरवेंशन शुड बी एक्टिवली परसूड इन ऑल पीपल विद COPD. ये लेवल ए एविडेंस है, बेस्ट क्वालिटी एविडेंस है. इफिशिएंट वेंटिलेशन, नॉन पोल्यूटिंग कुकिंग स्टोव्स, सिमिलर इंटरवेंशन शुड बी रिकमेंडेड, ये लेवल बी है. क्लिनिशियन शुड एडवाइज पेशेंट टू अवॉइड कंटिन्यूड एक्सपोजर टू पोटेंशियल इरिटेंट्स इफ पॉसिबल, ये लेवल. So for smoking cessation, every patient who is smoking should be asked to quit, should be advised, and should assess also, determine willingness and rationale for patient desire to make a quit attempt. Then उसको assist करना, मान लिया अपने से नहीं कर पाता, आपने बहुत ही अच्छा उसे काउंसलिंग किया, फिर भी वो नहीं छोड़ पा रहा, तो उसको आपको मेडिकल मैनेजमेंट से करना है. And arrange schedule for follow up visits, जिसे हर बार उसको समझाना है, कई बार छोड़ने के बाद फिर से शुरू हो जाते हैं, तो उन पर कंटिन्यूड प्रेशर और वॉच रखना है और उन्हें समझाते रहना है कि ये इट इज़ ऑलवेज हैजार्डस टू यू. जिन्हें COPD हो गया उनके लिए तो खतरनाक ही स्थिति है, आगे जब करेंगे तो उसे मतलब आपका जैसे सजेस्टिव पावर इतना होना चाहिए कि वो आपकी बात को माने. जैसे TB में हम लोग दवा देते हैं, अगर कई बार क्या होता है कि मरीज छोड़ देता है, लेकिन हम लोगों का शायद ही कोई मरीज छोड़ता है, बिकॉज इनिशियली वी काउंसिल, वी एजुकेट देम, सो इट शुड बी डन प्रॉपरली. ट्रीटिंग टोबैको यूज एंड डिपेंडेंस. सो द गाइडलाइन है डिटेल इन क्वाइट डिटेल, सो आई विल नॉट गो इन डिटेल बिकॉज टाइम आई थिंक इज लेस. सो वैक्सीनेशन फॉर स्टेबल COPD. Influenza vaccination is recommended for people with COPD, evidence B. The WHO and CDC recommends SARS-CoV-2 vaccination. ये तो सभी को लगा, फोर्सफुली लगा, गवर्नमेंट ने काफ़ी उस समय लगवाया, तो ये सबको लगा. अभी आई थिंक वल्नरेबल ग्रुप के लिए अवेलेबल होगा. सो एविडेंस B. CDC recommends 1 dose of 20 valent pneumococcal conjugate vaccine, PCV20, and 1 dose of 15 valent pneumococcal conjugate vaccine, PCV15, followed by 23 valent pneumococcal polysaccharide vaccine, PSV23, for people with COPD, evidence class B. Pneumococcal vaccination has been shown to reduce the incidence of community acquired pneumonia and exacerbation of people with COPD. The CDC recommends the new respiratory syncytial virus vaccine for individual over 60 years and are with chronic heart or lung disease. This is class A evidence. CDC recommends Tdap vaccine to protect against the pertussis, whooping cough, for people with COPD that were not vaccinated in adolescence. And zoster vaccine protect against the shingles for people with COPD over 50 years. These are level B evidences. So initial pharmacological treatment. So according to जो अभी हमने AB group करा है, उसके accordingly treatment plan है. For group A bronchodilator, for group B LABA plus LAMA, and for group E LABA plus LAMA, and consider if this eosinophil, blood eosinophil level more than 300 are equal to 300, then should be ICS should also be added, and according to their history of exacerbations also. And this is important that if possible, single inhaler therapy may be more convenient and effective than multiple inhalers, because there will be good compliance and good acceptance from the patient side also. So management cycle का होगा क्या होगा, review करिए symptom dyspnea exacerbation, assess करिए inhaler technique and adherence, non-pharmacological approaches, and then adjust according to your findings of assessment. You can adjust the treatment. You may escalate as per need or de-escalate as per the need of the patient. So follow pharmacological treatment. Suppose there is a for dyspnea, LABA or LAMA, or maybe combine both at the same time. And for exacerbation, LAMA or LABA, and if this eosinophil is more than 300, LABA plus LAMA, and this बहुत छोटा आवाज दिख रहा होगा नहीं दिख रहा होगा. So according to eosinophil levels, अगर 300 से ज़्यादा है तो LABA plus LAMA plus ICS, and according to need and assessment, you can escalate or de-escalate the treatment. Key points for inhalation of drugs. When a treatment is given by the inhaled route, the importance of education and training inhaler device technique cannot be overemphasized. जैसे मान ली हमने उसे MDI दिया है, तो उसे हम और एजुकेट करें कहीं नहीं यही लेना है, ऐसा नहीं है. कंपेल नहीं करना, उसकी चॉइस भी पूछना है, अकॉर्डिंगली वी शुड गिव. द चॉइस ऑफ इनहेलर डिवाइस हैज़ टू बी इंडिविजुअली टेलर्ड and will depend on access, cost, prescriber, and most importantly, patient's ability and preference. It is essential to provide an instruction and demonstrate the proper inhalation technique when prescribing a device, to ensure the inhaler technique is adequate and to recheck each time the patient continues to use their inhaler properly. Basic principles of appropriate inhalation device, I will not go in detail, it is quite more text. So non-pharmacological management of COPD. So patient group A, group grade A है, grade B or E का है, accordingly we will decide. So for group A, influenza vaccination, COPD, influenza vaccination, COVID-19 vaccination, pneumococcal vaccination, pertussis vaccination, shingles vaccination, and respiratory syncytial virus vaccination. Any group, the vaccination schedule is same, but this pulmonary rehabilitation for advanced COPD, I mean the B group grade B and E is recommended pulmonary rehabilitation. Otherwise, for group A, you can recommend physical activity to be improved. So follow-up of non-pharmacological treatment, timely it should be seen that how well they are doing, how much they have improved. For the oxygen therapy and ventilator support also these guidelines have addressed, and this group grade A evidence you can see here. So for prescription of supplemental oxygen to COPD, so arterial hypoxemia define PaO2 less than or equal to 55 mmHg, or PaO2 more than 55 mmHg plus right heart failure or erythrocytosis. So prescribe supplemental oxygen and titrate to keep the SaO2 more than or equal to 90%. So there is a criteria, we all know how to prescribe and how to do. Palliative care and end of life and hospice care in COPD. All clinicians managing patient with COPD should be aware of effectiveness of palliative approaches and symptom control and use of these in their practice. It is evidence D. End of life care should be included in decision with the patient and their families. Opiates, neuromuscular electrical stimulation, oxygen and fans. These are few recommendations, not so strong. So evidence supporting the reduction in evidence supporting a reduction in mortality and pharmacotherapy and non-pharmacotherapy in COPD. So symptomatic people with a history of frequent or severe exacerbation. इन लोगों को जैसे ट्रिपल ड्रग कॉम्बिनेशन हो गया लावा लामा एंड ICS. नॉन फार्माकोलॉजिकल में क्या है, सब एसिम्टोमेटिक है और माइल्डली सिम्टोमेटिक, उन्हें स्मोकिंग सेसेशन. और इससे जो हायर ग्रुप है उनके लिए पल्मोनरी रिहेबिलिटेशन, लॉन्ग टर्म ऑक्सीजन थेरेपी, नॉन इन्वेसिव पॉजिटिव प्रेशर वेंटिलेशन, लंग वॉल्यूम रिडक्शन सर्जरी अकॉर्डिंग टू देयर current status can be recommended. These are various medication for maintenance medication in COPD. I will not go in detail. We know we are lucky that we have very all kinds of drugs available in our for our patients, and we can select accordingly. So anti-inflammatory therapy in stable COPD, inhaled corticosteroid, oral corticosteroid, PD4 inhibitors, antibiotics, and management of additional agents, antioxidants, management and म्यूको जैसे म्यूको क्या कहते हैं हम म्यूकोलिटिक म्यूकोकाइनेटिक ड्रग्स का यूज़ क्या होगा, ये इसके लिए एड्रेस किया है कि ये किस लेवल का एविडेंस है. एंड अदर एंटी इन्फ्लेमेटरी ड्रग्स. तो अभी स्पेशली वी शुड नो वेयर टू यूज़ इनहेल कॉर्टिकोस्टेरॉइड. सो स्ट्रांग रिकमेंडेशन कहाँ है, जैसे हिस्ट्री ऑफ हॉस्पिटलाइजेशन फॉर एक्सेसरबेशन ऑफ COPD. अगर मोर देन 2 मॉडरेट एक्सेसरबेशन ऑफ COPD पर ईयर है, उसमें और देखिए ब्लड यूसिनोफिल 300 और उससे ज़्यादा है, उसमें हिस्ट्री ऑफ कंकमिटेंट एजमा है. तो इस ग्रुप में इनहेल कॉर्टिकोस्टेरॉइड इज स्ट्रांगली रिकमेंडेड. और अगर यूसिनोफिल का लेवल 100 to 300 है, इसमें इट कैन फेवर द यूज़. बट एक ग्रुप है जिसमें बिल्कुल ही आपको नहीं लिखना है. रिपीटेड निमोनिया इवेंट्स हो रहा, ब्लड यूसिनोफिल लेस देन 100 सेल्स पर माइक्रोलीटर, हिस्ट्री ऑफ माइकोबैक्टीरियल इन्फेक्शन. तो इस ग्रुप में बिल्कुल ही नहीं निकला है. सो इट इज़ कंट्राइड इंडिकेशन. दिस इज़ द बेस्ट ग्रुप टू प्रेस्क्राइब. Other pharmacological agents, alpha-1 antitrypsin deficiency, very specific group. Then antitussive, vasodilator, opioids, pulmonary hypertension therapy group. So according to the case, you can select and advise. Pulmonary rehabilitation and self-management and interactive care in COPD. So pulmonary rehabilitation, अभी सर बता रहे थे कितना इसका रोल है. It is level A evidence. And education and self-management, it also has a role, definite role in integrated care programs, level B evidence, and physical activity it is a level A evidence. So अभी सर बता रहे थे कि कैसे आपको जैसे ट्रांसप्लांटेशन से पहले उसे फिजिकल पल्मोनरी रिहेबिलिटेशन देना है to improve their physical activity, and it is also will be good prognostic indicator post lung transplant. Overview of current and proposed surgical and bronchoscopic intervention. अभी सर बात कर
kind of whatever armamentarium we have, the data and the guideline is robust, how to treat them, right from pharmacological to non-pharmacological management. So we have very nicely highlighted all the aspects of the latest updates of the guidelines. Sir. So with this, I'll just ask my
मैं और
coach.
बताऊंगा जैसे हम लोग बात जरूर कर रहे हैं लेकिन जो जो प्रॉब्लम है इतनी बड़ी है शायद जो स्मोकिंग इतनी प्रिविलेंट है आप किसी को मिले जो स्मोक करता हो आप कभी छोड़ दो नहीं छोड़ेगा जब तक वो मजबूर नहीं हो जाता है किसी को कैंसर डिक्लेयर हो गया तुरंत छोड़ देता पूरा परिवार छोड़ देता सब दोस्त छोड़ देते हैं लेकिन अगर यूजुअल सजेशन जैसा हम लोग दे रहे हैं पेपर में भी बहुत आएगा लेकिन इसकी एक्सेप्टेंस कम जब तक लिटरेसी लेवल नहीं ऊपर जाएगा लोगों तक इसकी पहुंच नहीं होगी शायद इसकी अवेलेबिलिटी हम लोग हटा दें तो और अच्छा है तो जैसे कोई मेहमान आता तो जैसे गांव में क्या बीड़ी सिगरेट उनके लिए पहले अरेंज करो जिसका जो शौक है ठीक है अपने लोगों में से जब मूड में आते हैं तो शुरू कर देते हैं
हिल गया था क्या
एक्चुअली गाइडलाइन में उसको बहुत डिटेल में दिया है कि वो उसका यूज रिकमेंडेड करा जाता है बस ये है कि जैसे सिगरेट और बीड़ी के रूप में जो तंबाकू ले रहे हैं उसको छोड़ के खैनी न खाने लग जाएं ठीक है तो उनको किसी रूप में तंबाकू खाएंगे तो वो नुकसानदेह है जी किसी रूप में टोबैको इन एनी फॉर्म इज डेंजरस और सीओपीडी मल्टी सिस्टम डिसऑर्डर है हार्ट भी इन्वॉल्व होगा पूरा न्यूरोमस्कुलर सिस्टम इन्वॉल्व होगा
थैंक यू सर एनी क्वेश्चंस और कमेंट्स
अभी हमने काफी स्लाइड हटा दिया इसमें
Thank you, sir, for this wonderful session. Now I invite Professor Ved Prakash, sir, to come on stage and felicitate our speaker, Professor R.A.S. Kushwaha, sir. Now I invite our chairpersons to come on stage and get felicitated. Dr. K.B. Gupta, sir. Dr. Ajay Kumar, sir. Dr. Anand Kumar Srivastav, sir. Dr. Sachin Kumar, sir. Moving ahead with our next session, I would like to invite the chairpersons of our next session, Dr. Heather Abbas, sir, Professor and Head, Emergency Medicine, KGMU. Dr. Avinash Agarwal, Professor and Head, CCM KGMU.
मेरा सीवी क्यों लगा है, इसको हटाओ, सीवी हटा दो. Okay, so I'll try and brief you in the coming 20 minutes as to what you do for AE-COPD patients when they present to the ED. And I will not be focusing on some of the very controversial areas that come in management of AE-COPD because there are many. Like, I'll just enumerate 5 of them to you, like use of PDE4, use of the steroid dose, how much, pulse, no, yes, soda bicarb versus Diamox, then use of HFNC, which I'll probably touch. Then there are a few more which have evolved, like PDE4 inhibitors ko kab use karna hai, kab. So there are 5 or 6 controversial areas in management of AE-COPD, which I'll probably will not touch because it will take too much of your time. So if there are questions on those, I will definitely love to answer them. So since it is an ED, so triage is important. We need to understand what sort of patient is coming. The previous speaker has already enumerated a lot of things about the gold current criteria and diagnostic, but we are dealing with unstable COPDs in the ED. So the patient will come with clinical severity. You need to do a clinical examination. You need to have certain basics of like pulse oximetry. You may have to start a supplemental oxygen therapy. You may have to do a VBG versus ABG. Again, controversial, but VBG is now being promoted more in the EDs compared to the ABGs. Then you will do and obtain a minimum number of set of investigations which have been enumerated. But remember, it is triaging. You can't waste time. Investigations, except the VBG, which will be done almost immediately, or an ECG, which will be done immediately. Ultrasonography has penetrated almost any segment. So for the triaging segment itself, ultrasonography will come because chest x-rays will take you another 30 minutes to 2 hours for the reporting to become. And you have to decide whether this patient is actually in CHF or in a COPD related element or a cor pulmonale or a pulmonary embolism or a pneumonia or any other element related to that. So for a management of AE-COPD coming to the ED, ultrasonography is #1 modality according to us to help you decide the management. Then we need to categorize. Categorization clinically जो हम आज और पहले भी learn करते हैं वो इन्हीं 4 criteria पे होता है. Respiratory rate, accessory muscles use कर रहा है नहीं कर रहा है. Then the mental status of the individual. Then the degree of hypoxemia he has and the hypercapnia level that he has. And this is how you categorize them, and therefore the further elements will come only when you fit these values into this. And then it comes like this, because it is an ED. You need to decide whether it is an AE-COPD which is life-threatening in nature or not. It's an emergency. Whether or not it is a stable AE-COPD who has just landed because some symptoms have started to come. or it is an ASCOPD which is non-life threatening. So अभी तक gold में जितना भी you have read in the last lecture is the left hand segment or the right hand segment एकदम last में stable COPD. आज के lecture में इसमें हम stable COPD बिल्कुल बाहर कर रहे हैं. Okay, we are dealing only with the unstable क्योंकि ASCOPD के exacerbations when they happen either more than twice a year or the intensity of the sputum or the purulence nature of the sputum is changing, they become more sicker and they are likely to be developing more severity. Therefore, we need to understand that we dealing with in the emergency with life threatening and not life threatening, बस यही differentiate करना जरूरी. ट्राइजिंग के पॉइंट्स में ही इसके मैनेजमेंट यहीं से डिसीजन शुरू हो जाते हैं एंड देन लेट अस सी ओनली द वंस विच हैव बीन earmarked into this. Life threatening, either an immediate trial of NIV has to be given to this patient. Second, if it is non-life threatening, it is a plus minus, you can give him a trial of NIV. If you give him a trial of NIV, then there is a time period in which you have to decide whether it is a 30-minute or a 2-hour period. Within this period, you have to decide whether this patient moves into the ICU or will remain in your area because he is improving. So these are simple things that will be done in the ED, and as a resident in ED or a physician in ED, you have to decide these simple things for your patient. Life-threatening segment, then there are 4 or 5 things that are already done. There is a triple therapy which has been recommended currently for, that is which includes LAMA, LAVA and ICS. ये recommendations हैं for patients who are not doing well with SABA, SAMA and the ICS. Then we add on to the LAMA, LABA and the ICS. ये recommendations हैं. Then there is another element which has come into it is the level of eosinophil counts in these patients. Okay, whether it is less than 300, whether it is less than 100, the higher the eosinophil, it is suggested it could be a viral episode. And therefore, sometimes initiation of an antibiotic, which is like a knee-jerk reaction for all ACOPDs, may not be relevant. So some literature is evolving in that area. So if the eosinophil count is less than 300 or it is less than 100, there are chances it could be a bacterial element and therefore the antibiotic comes. When the eosinophil count is more, then steroids come. So decision tree thoda sa evolve ho raha hai. Maybe in coming times you will have newer drugs like roflumilast into these areas based on the eosinophil counts. Okay, just controversial areas ke baare discuss kar rahe hain. Then once you decide this, whether high dose SABA and SAMA is, because these are breathless patients, आप इनको नेबुलाइज कैसे करेंगे? ये तो नेबुलाइज ले ही नहीं पाएंगे, सिंगल ब्रेथ में एंट्री जाएगी ही नहीं. सो दे आर गैस्पिंग. सो समटाइम्स दीज ड्रग्स जो इनहेल जरूर लिख रहे हैं, रिकमेंडेशंस हैं कि फिर भी ट्राई करो, जितना भी चला जाए दे दो. बट फॉर आवर क्लिनिकल एक्सपीरियंस हमने देखा है जो पेशेंट ब्रीथ ही नहीं कर पा रहा है, ये ड्रग्स डिलीवरी नहीं होंगे. तो उन केसेस में क्या करते हैं, यूजुअली हम ICS ना करके इंजेक्टेबल स्टीरॉइड्स पे जाते हैं. देन द डोजेस कैन बी, इट कैन बी अ डच बिटवीन पल्स डोज, इट कैन बी मिथाइल प्रेडनिसोलोन्स और सोल्यूमेट्रॉल इंजेक्टेबल फॉर्म्स जो कि हम जाते हैं डोज में, उसमें वील टॉक अबाउट द डोजेस. And then again you have to see whether this patient is recovering or not recovering within the next 30 minutes to 2 hours is your transition time. Is he going to get intubated? Then there are definite indications वो already लिखे हैं. अगर patient को altered mental status है, PO2 और 40 के नीचे है despite your oxygen delivery, pH 7.5, severe dyspnea which is refractory to the medical therapy, inability to protect the airways, inability and a high risk of aspiration, instability, these are all features which tell me that this patient has to go into the ICU, not in the ED itself. So further categorization is based on this. Oxygen, हर जगह oxygen के बारे में बड़ी in COPD always talk of oxygen. Stable के लिए 88 to 92 है, प्लीज़ ये ध्यान रखिएगा. Stable patient के लिए 80 to 92 है, लेकिन अनस्टेबल पेशेंट के लिए आप थोड़ा सा और ऊपर जाते हैं. PO2 का टारगेट देखिए 70 के नीचे नहीं है, उसमें थोड़ा सा ऊपर रखना है. बिकॉज लास्ट लाइन सेज कि टिश्यू हाइपोक्सिया, यू कैनॉट क्रिएट टिश्यू हाइपोक्सिया फॉर अ पेशेंट और केवल CO2 के बारे में सोचते रह जाएं. तो इट इज़ अ डच बिटवीन द टू. येस, CO2 इज़ इम्पॉर्टेंट बिकॉज पेशेंट की ऑक्सीजन ड्राइव पे उसका रेस्पिरेटरी रेट चल रहा है. When you give him more oxygen, there will be a dutch कि he will get into a less breathless state, from more breathless to less breathless, but his sensorium will also deteriorate. That is definitely there, evidence भी है इसके favor में. But there is a slight change in the philosophy now कि ऑक्सीजन देना है, टिश्यू हाइपोक्सिया नहीं क्रिएट करना है. PO2 का टारगेट 60 नहीं है जो कि स्टेबल COPD के लिए है. इसका COPD का टारगेट अनस्टेबल COPD में 70 है. वाई 70 मैं बस ये बता दूं, 70 इसलिए रख रहे हैं कि आपके पास रिएक्ट करने के लिए समय होना चाहिए. वो 10 का मार्जिन एक्स्ट्रा दिया गया है, नहीं तो मैं 60 पे खेलते इस पेशेंट के अंदर. लेकिन COPD जो अनस्टेबल है उसमें हम 60 पे नहीं खेलते हैं, हम 70 पे प्ले करते हैं. हम सैचुरेशन 92 पे रखते हैं, 88 पे नहीं सोचते इस पेशेंट्स में जो कि डिटोरेट करते हुए मेरे पास आ रहे हैं. ओके, सो देयर इज़ अ मार्जिन. आप भी जस्ट इस चीज़ को रियलाइज़ करिएगा. फार्माकोलॉजी में सब कुछ है जो आप सीखते हैं, लेकिन जब हम इमरजेंसी में काम करते हैं तो हर चीज़ ABCD में करते हैं. तो ABCD बंडल फॉर COPD में यही सारी चीज़ें हैं, इन्हीं ड्रग्स को आप देना है आपने. A फॉर एंटीकोलिनर्जिक्स यानी कि and preferably longer acting LAMA, and then B for beta agonist, C for inhaled versus injectable आ जाता है इसके अंदर. Then D for roflumilast जो अभी हमने बताया based on the eosinophil count. अगर आपके पास जल्दी से आ जाए then you can decide on this treatment. Education and ये सब पुराना है गोल्ड के हिसाब से कि आप एजुकेट करें, दोबारा अटैक ना हो. You have to do all this, and friends, family and everybody is important in this, and vaccination prevention के लिए important है. ये इमरजेंसी में हम इस तरह से इसको रिलेट करते हैं रादर दैन दोज ड्रग्स. जो पिंक में है आप लेफ्ट साइड में देख रहे हैं वो फार्माकोलॉजिकल मैनेजमेंट है. COPD की डोजेस में फ़र्क है. ओके, नई कोई ड्रग नहीं है, डोजेस में फ़र्क है. राइट साइड में स्टेबल की लिखी हैं, लेफ्ट साइड में अनस्टेबल के लिए लिखी हैं COPD की. बस डोजेस की फ्रीक्वेंसी बढ़ जाती है, इतना ही डिफरेंस है बस. कोई चमत्कारिक नई दवा नहीं है, चाहे वो इमरजेंसी में आए, चाहे वो ICU में आए, चाहे वो आपकी OPD में आए. ड्रग्स की फ्रीक्वेंसी बढ़ा दी जाती है और डोज बढ़ती है. नेक्स्ट अभी हमने बताया NIV का यूज़ करना है. ये एल्गोरिदम सब जगह चलता है, NIV को कैसे यूज़ करना है COPD के ऊपर. तो ये प्लस माइनस है. अगर इनमें से जो ब्लू बॉक्स में जो भी दिया है, डिस्पाइट मैक्सिमल मेडिकल थेरेपी pH 7.2535 पे रहे, कॉन्शियस है, कोऑपरेटिव है, प्रोटेक्ट कर सकता है, हीमोडायनेमिकली स्टेबल है, तो NIV देता है. बस इतना ही डिसीजन है हिस्ट्री में, NIV देना है. ओके, ये पैमाने अगर फुलफिल हैं देन यू हैव टू गिव देम NIV टू दीज पेशेंट्स. इसमें कोई चेंज नहीं है. मैं 10 साल पहले शायद लेक्चर दे रहा था और आज भी दे रहा हूँ, तो इसमें अभी भी वही सेम है स्टेटस. ओके, एल्गोरिदम में थोड़ा सा ऑल्ट्रेशन, ये 4-5 साल पुराना है. इसमें हाइपरकैप्निया की लेवल्स में थोड़ा बहुत फ़र्क आया होगा. 6.7 माने 1 kPa होता है 7.5 mmHg का, तो 7 से इसको मल्टीप्लाई करूँगा लगभग 50 के आसपास आता है. PSO2 50 के ऊपर जा रहा है और pH को देखना है. pH लेस देन 7.25 है. 2 घंटे का ट्रायल दे दिया, पेशेंट इंट्यूबेशन की तरफ जा रहा है. केवल इतना ही है इसके एल्गोरिदम में. PSO2 बढ़ रहा है, pH पेशेंट का 7.25 से बेटर नहीं हो रहा. आपने 2 घंटे का ट्रायल दे दिया, पेशेंट इंट्यूबेशन की तरफ जा रहा है. ये ओके, केवल इतना ही है. ये देखने में कॉम्प्लिकेटेड बट डिसीजन टेकिंग इतना ही है इसके अंदर. ओके, ये प्रोटोकॉल बिल्कुल ऐसा ही चलता है NIV को यूज़ करने के लिए. इसमें कोई भी चीज़ें स्पेसिफिक नहीं है. आपको प्रॉप्ड अप रखना है, बेड एंड रखना है, डिहाइड्रेट नहीं करना है पेशेंट को. आपको डर होता है कि COPD में मैं ज़्यादा पानी दूंगा तो इसके लंग्स और हैवी हो जाएंगे, लेकिन टिश्यू हाइपोक्सिया क्रिएट करके आप पेशेंट को ड्राई करेंगे, वो एक्सेप्टेबल नहीं है. आप देखिए ये पेशेंट इनहेलर ले रहे होते हैं, रैपिड आप NIV देंगे तो ड्राई हो जाते हैं. तो आपको हाइड्रेशन के इश्यूज़ को ध्यान रखना है COPD के पेशेंट को मैनेजमेंट करते हुए. ड्राई आप ब्लैसिक्स तो दे रहे हैं दबा के, डाइटोर भी दे रहे हैं, लेकिन ये नहीं देख रहे कि इससे मेरे पेशेंट का टिश्यू हाइपोक्सिया क्रिएट हो रहा है, वॉल्यूम नहीं जा रहा, पल्मोनरी आर्टरी में ब्लड सप्लाई आपने इतनी ड्राई कर दी, तो आप डेड स्पेस वेंटिलेशन क्रिएट कर रहे हैं अपने पेशेंट के लिए उसी लंग के अंदर. तो यू हैव टू बी केयरफुल. तो ओवर ड्राई भी नहीं करना है, मतलब ओवर ड्राई नहीं करना है, लेकिन ओवर हाइड्रेट भी नहीं करना है. तो बैलेंस है, वो डिसाइड कैसे करेंगे, इसलिए अल्ट्रासोनोग्राफी आ गई. आप डिसाइड कैसे करेंगे कि ओवर हाइड्रेटेड है कि अंडर ये डिहाइड्रेटेड है? देयरफॉर अल्ट्रासोनोग्राफी कम्स इनटू द पिक्चर हियर. इंटरफेसेस जरूर बात होगी जब भी आप बात करेंगे एनआईवी के बारे में. इंटरफेसेस बहुत सारे हैं. हमारा फेवरेट राइट साइड वाला है जो कि हम ज़्यादा यूज़ करना चाहते हैं क्योंकि वो वेंटिलेटर से कनेक्ट होता है, सबसे ज़्यादा कंफर्टेबल है. कॉस्ट 5 टाइम्स ज़्यादा है आपके किसी भी एनआईवी मास्क से, लेकिन इसकी ड्यूरेबिलिटी बेटर है. आप कंफर्ट लेवल बहुत ज़्यादा है इसमें. बस ये ऊपर से फिट होना चाहिए. तो पेशेंट अगर अनकॉन्शियस है तो इसको फिट करने में दिक्कत आएगी क्योंकि कोऑपरेट नहीं करेगा. इसलिए एनआईवी कोऑपरेटिव पेशेंट, स्टेबल पेशेंट जो आपसे इंटरेक्ट कर सकते हैं, जो वॉमिट नहीं कर रहे, जिनका इंट्रा एब्डोमिनल प्रेशर बहुत फूला हुआ नहीं है, उनके लिए होता है. तो दिस इज़ वन विच वी यूज़. रिस्क है, जिसमें भी लगाएंगे फेल होंगे. एनआईवी जिसको भी लगाएंगे फेल होंगे. किस में फेल होंगे ये पता होना चाहिए. तो ये जितने भी ब्लू में ऊपर लिखे हुए हैं, जिनको भी वो सब चीज़ है वो सब फेल होने वाले हैं एनआईवी. क्योंकि 2 घंटे का ट्रायल है ना, आप एनआईवी देने वाले हैं तो पहले ही पता होना चाहिए फेल होने वाला है. तो ये सारे क्राइटेरिया हैं फेल होने के लिए, जिसमें पुअर जीसी है, जीसीएस लेस देन 11 था, आपने यूज़ किया, फेल का रिस्क है. टैकिपनिया 35 से ऊपर ब्रीथ कर रहा है, फेलियर का रिस्क है. पीएच 7.25 के नीचे जा रहा है, रिस्क है. अपाची स्कोर 29 के ऊपर है, रिस्क है. एसिंक्रोनस ब्रीदिंग बाईपैप लगाने के बाद भी पैराडॉक्सिकल ब्रीदिंग उसकी चल रही है, रिस्क है. इडेंटिलस है, दांत नहीं है मरीज के, रिस्क है. ये सब फेल होने वाले पेशेंट्स हैं आपके. तो आपको आइडेंटिफाई करना ही पड़ेगा किस में एनआईवी. ये सब ईडी में हो रहा है, ये सब आईसीयू में भी यही होएगा. ओके. ये स्कोर को यूज़ किया जाता है कि अगर मैं पहले 2 घंटे में डिसाइड नहीं कर पा रहा तो कुछ नर्सेज की ज़रूरत पड़ेगी मुझे देखने के लिए. ये सारी चीज़ें नर्सेज कर सकती हैं, डॉक्टर की ज़रूरत नहीं है. नर्सेज कैन डू दिस सिंपल थिंग. अगर पहले फर्स्ट हडल, यानी ये मैसेच्यूसेट्स जनरल हॉस्पिटल का है, ये चेकलिस्ट होती है, इसको हडल बोलते हैं, हडल चेकलिस्ट यूज़ करते हैं. तो जो रेड वाले हैं आप बस देखिए, फर्स्ट हडल में अगर कोई भी आंसर येस है वो नर्स भी बता देगी, तो इसका मतलब ये चल सकता है और दे सकते हैं इसका ट्रायल. अगर देने के बाद में आप जब सेकेंड हडल करेंगे 2 घंटे बाद, जब आपने हडल किया और इसमें कोई भी आंसर नो आ गया ग्रीन वाला, तो इसको तो इंट्यूबेशन या आईसी ट्रांसफ़र होना है. बस इतना ही सिंपल काम करना है. ओके. यही ईडी में होगा, यही आईसीयू में होगा, यही किसी भी पल्मनरी वार्ड जहाँ पे कि बाईपैप लगा रखा है सीओपीडी पेशेंट को, दैट ऑल्सो यू हैव टू डू. तो दीज आर सिंपल थिंग्स नर्सेज कर सकती हैं. डिलीवरी आपको अब थोड़ा सा स्टेबल हुआ, आपको उसको नेबुलाइज करना है. तो डिलीवरी, एरोसॉल डिलीवरी ड्यूरिंग एनआईवी इज़ अ वेरी कॉम्प्लिकेटेड इशू. आधे से ज़्यादा पेशेंट्स को आपने जिनको एनआईवी लगाया उनको आप एरोसोलाइज नहीं कर रहे होते हैं, देते ही नहीं हैं. ये जाएगा ही नहीं, डिलीवरी नहीं सही होगा, वो फ्रीक्वेंसी ख़राब हो जाएगी, सारा मुंह से लीक कर जाएगा. सो देयर इज़ लॉट ऑफ लिटरेचर ऑन दिस एरिया कि इनकी डिलीवरीज को कैसे आप बेटर कर सकते हैं. आई एम जस्ट टचिंग दिस एरियाज. वेंटिलेटर रिलेटेड, सर्किट रिलेटेड, डिवाइस रिलेटेड, ड्रग रिलेटेड, ब्रेथलेस पैरामीटर्स, टाइप ऑफ इंटरफेस, डिवाइस रिलेटेड, नेबुलाइजर, ये सारे पैरामीटर्स हैं जो डिसाइड करेंगे एक एसीओपीडी के लिए कि डिलीवरी कैसे होनी चाहिए आपकी नेबुलाइजिंग ड्रग्स की. ओके. जस्ट अ मेंशन, जो लोग पढ़ना चाहें वो रीड कर सकते हैं. ट्रबल शूटिंग में 2 ही ट्रबल शूटिंग आपको आनी चाहिए. या तो PO2 लो है तो क्या करेंगे, एक बाईपैप सिस्टम या एनआईवी पे, उसमें आपको रेड में नीचे लिखा हुआ है. अगर PCO2 ज़्यादा है तो इनमें से कुछ ना कुछ ज़रूर होगा गड़बड़. तो you have to decide on these factors. Either it is too low or it is too high a PCO2, then there is a definitive troubleshooting. Normally NIV patients जो COPD के हैं उनको NIV रेट जो IPAP लगाते हैं वो 10 और 14 के बीच में यूज सेटेड. EPAP 4 to 5 है और ऑक्सीजन फ्लो रेट 2 to 4 है, ये वो सैचुरेशन लगाते हैं. न्यूअर NIVs have got FiO2 meters. They can tell you how much FiO2 is going on. हम लोग क्या करते हैं, we put it onto the ventilator. तो हमें पता रहता है. दैट इज़ वन वे ऑफ डूइंग इट. HFNC और NIV, अभी हमने बोला कि ज़्यादा ऑक्सीजन इज़ डेंजरस, लेकिन HFNC यूज़ हो रहा है इन COPD. हाइपॉक्सिक रेस्पिरेटरी फेलियर, टाइप 1 रेस्पिरेटरी फेलियर हम समझते हैं HFNC अच्छी चीज़ है, लेकिन टाइप 2 रेस्पिरेटरी फेलियर जहाँ पे CO2 बहुत हाई है, PO2 गिर रहा है, वहाँ पे HFNC यूज़ करके ट्रायल करें. 7 RCT 480 पेशेंट्स, सब ने बोला कि ये NIV से इन्फीरियर नहीं है. ठीक है, बिल्कुल लेटेस्ट है. आई थिंक दिस इज़ 2023 अभी का निकला हुआ है, कैनेडियन रेस्पिरेटरी जर्नल. तो पहले यानी कोविड के पहले का सिनेरियो अगर मैं COPD का देखूं तो HFNC नहीं था. कोविड में HFNC का इतना यूज़ हुआ, इतना नॉलेज एक्सप्लोर्ड हो गया कि अब लोग उससे और कंफर्टेबल हो गए हैं। HFNC यूज़ कर रहे हैं, देखिए इन पेशेंट्स में टाइप 2 रेस्पिरेटरी फेलियर में भी ट्राई करके देख रहे हैं। ओके, मरता क्या ना करता वाला सिचुएशन है भाई, अगर बाईपैप से इम्प्रूव नहीं कर रहा है, इंट्यूबेट होने वाला, अच्छा ट्राई करके देख लो, HFNC देख लेते हैं। लेकिन आपको फ्लो देखना पड़ेगा, 20 लीटर्स, 40 लीटर्स, 60 लीटर्स, दैट यू हैव टू डिसाइड कि कितना उसको लिए करना है। तो ये नॉन इन्फीरियर है फिलहाल अकॉर्डिंग टू दीज 7 RCTs फॉर AE COPD पेशेंट्स। दिस इज प्योरली AE COPD। ओके, डिसीशन इंट्यूबेट करना है कि नहीं करना है, ये सारे क्राइटेरिया जरूर डिसाइड करते हैं। अभी लास्ट लेक्चर में, आई थिंक लास्ट लेक्चर में बोर्ड इंडेक्स के बारे में इट वाज बीइंग टॉक्ड ऑफ। तो किन को इंट्यूबेट करना है ये इन क्राइटेरिया पे डिसाइड करता है कि फंक्शनल स्टेटस, पेशेंट के विश, ऑक्सीजन रिक्वायरमेंट, कोमोबिडिटीज, प्रीवियस ICU एडमिशन। लेकिन बहुत सारी झूठ बोलते हैं हम लोग एज ए डॉक्टर। हम COPD पेशेंट्स को जिनको इंट्यूबेट करने वाले होते हैं, हम सीधा झूठ का पुलिंदा शुरू होता है। एक एक झूठ मैं बता देता हूँ। पहला झूठ, ये वेंटिलेटर पे गया तो कभी निकलेगा नहीं, हम इसे निकाल नहीं पाएंगे, डाल तो देंगे, ये इतना खराब है कि वेंटिलेटर पे जाएगा तो कैसे निकलेगा, ये तो बेड ब्लॉक कर देगा। रेजिडेंट डॉक्टर्स और डॉक्टर्स, यार बेड ब्लॉक हो जाएगा, इसको इंट्यूबेट मत करना, समझ ले तो, ठीक है। ये सारे झूठ है जो हम बोलते हैं एज ए डॉक्टर। मैं खुद भी बोल रहा हूँ, मैं भी बोलता हूँ, बहुत सारे ऐसे COPD पेशेंट्स आते हैं और मेडिकल फ्रेटर्निटी में बहुत सारे लोग जानते हैं कि हम बोलते हैं ये सब चीज़ें। इतने ख़राब हैं, जो NIV से नहीं इम्प्रूव कर रहा तो वेंटिलेट ही क्यों कर रहे हो, ये सब झूठ है जो हम बोलते हैं। ये तो इरिवर्सिबल कंडीशन है, ये ठीक नहीं होगी, एंड स्टेज जा रहा है ये तो, इसको वेंटिलेट नहीं करेंगे, ठीक है। लास्ट लाइन आप देख लीजिएगा, पेशेंट्स जिनको सीवियर COPD है या AU COPD के अनस्टेबल वेरिएंट में आ रहे हैं, यानी 3 और 4 वाले क्राइटेरिया, यानी FEV1 जिनका 30% और 50% से नीचे वाले FEV1 है, उसको इंट्यूबेट करने वाले शुड नॉट बी डिनाइड इन्वेसिव वेंटिलेशन, ठीक है। तो यू हैव टू इंट्यूबेट देम इफ द नीड इज़ देयर एंड द इंडिकेशन इज़ देयर फॉर दीज पेशेंट्स। कुछ सिंपल चीज़ें याद रख लें, अगर आपको इंट्यूबेट करना पड़े, चाहे मैं ED में इंट्यूबेट करूँ चाहे ICU में। COPD जो काफ़ी FEV1 जिनका कम है, उनको इंट्यूबेट करने के कुछ बेसिक प्रिंसिपल्स होते हैं, वो सबको यही अप्लाई करने हैं, चाहे वो कहीं भी हो, चाहे ICU में, चाहे इमरजेंसी में, चाहे पोस्ट ऑप में। P-फ्लैट 30 के नीचे ही रखना है। ओके, डू नॉट वरी टू मच अबाउट द पीक प्रेशर्स। इनके पीक, क्योंकि ऑब्स्ट्रक्टिव एयरवे डिजीज़ है, पीक प्रेशर्स पे ज़्यादा दिमाग खपाने की ज़रूरत नहीं है, ठीक है। नेबुलाइज करिए। FiO2 को SpO2 90-92 अभी बताया था, जब आपने इंट्यूबेट कर दिया, सेडेट कर दिया, तुरंत निकलेगा नहीं, तो अपने दिमाग से इस कीड़े को निकाल दीजिए कि अब मुझे ऑक्सीजन इसकी 88 रखनी है, भूल जाइए, आपको टिश्यू हाइपोक्सिया क्रिएट नहीं करना है, तो 92 पे रखना है। एयरवेज गिव मोर टाइम फॉर एक्सपिरेशन, ये सिंपल रूल्स हैं, आप 1:2 रखते हैं, हम 1:3, 1:5 तक चले जाते हैं। ओके, दैट सिंपल प्रिंसिपल्स हैव टू बी। डू नॉट एम फॉर अ नॉर्मल PCO2, ये जल्दी नहीं आएंगे। 90 PCO2 पे पेशेंट को वेंटिलेटर पे डाला, 1 घंटे में चाह रहे हो रेजिडेंट से कि ये 40 पे लेके आएगा, इतना एल्कलोसिस क्रिएट करेगा, दिमाग एकदम ऑल्टर्ड हो जाएगा उस पेशेंट का, अगर नहीं था तो इट इज़ अ ग्रेजुअल वे ऑफ ब्रिंगिंग द PCO2 डाउन। वैसे भी इंट्यूबेट हो गया, कौन सा घंटे भर में निकलेगा, कौन सा 4 दिन में निकलेगा, कौन सा 1 हफ्ते बाद निकलेगा। तो डोंट बी इन अ हरी टू ब्रिंग डाउन द PCO2 वेरी फास्ट। pH टारगेट रखें, इसमें PCO2 टारगेट पे ना जाएं, केवल pH का टारगेट रखें। आप नॉर्मली जब करते हैं pH भी देख रहे होते हैं, PCO2 भी देख रहे होते हैं, जो स्टेबल COPD पेशेंट्स आते हैं आपके पास में। लेकिन इन किनारियोज में आप देखिएगा pH को देखेंगे। वॉच आउट फॉर डायनेमिक हाइपर इन्फ्लेशन, ये कॉमन प्रॉब्लम है क्योंकि ये ऑब्स्ट्रक्टिव एयरवे डिजीज़ है। आपने पीप 5 रखा लेकिन एक्चुअल पीप 10 हो गया पेशेंट का, BP गिरा हुआ, लंग फट जाएगा, न्यूमोथोरक्स हो जाएगा। तो ये डायनेमिक पीप जो कि हीमोडायनेमिक कॉम्प्रोमाइज़ क्रिएट करेगा, आप इसको ज़रूर देखें कि ये पीप इनएडवेंटली बहुत ज़्यादा पीप रखने के चक्कर में ना रहें, क्योंकि वो ऑटोमेटिकली इंट्रिंसिक पीप उस पेशेंट में होएगा ही होएगा। ओके, डायनेमिक हाइपर इन्फ्लेशन, थिंक अबाउट अर्ली, जल्दी निकालें। तो लॉन्ग टर्म सेडेशन, पैरालाइज कर दिया, लंबा दमा के 10 दिन तक मिडाजोलम फेंटानिल का ड्रिप लगा के रख दिया, छोड़ दिया, वेक भी नहीं किया, ये सब कभी ना करें COPD के लिए, क्योंकि आज अच्छा नहीं है, लेकिन 24 घंटे बाद शायद आपके कुछ पैरामीटर सही हो जाएं कि आप इसको हटाना पड़े। तो शॉर्टर सेडेशन यूज़ करें। हम इनमें प्रोपोफॉल यूज़ करते हैं क्योंकि रेस्पिरेटरी के लिए ये ब्रोंकोस्पाज्म को हेल्प करने के लिए बेटर होता है। फिर हम इसके अंदर कॉन्शियस सेडेशन यानी डेक्समेटाडोन पे ज़्यादा जाते हैं, मिडाफेंटा भी जाते हैं, तो रेगुलेट करते हैं। पैरालिसिस अवॉइड करते हैं, अनलेस बहुत डिफिकल्ट केस सिनेरियो हो हम अवॉइड करते हैं। तो दीज आर सिंपल थिंग्स जो आपको यूज़ करना है। और निकालते ही, अब ये नया लिटरेचर है, ट्यूब से निकालते ही या तो NIV पे जाएंगे, तो आप परफेक्ट मत बनाएं वेंटिलेटर पे। जब लगे कि PCO2 60 के आसपास आ गया, pH मेंटेन हो रहा है, सेंसोरियम सेडेशन स्टॉप किया, ठीक है, एक्सट्यूबेशन की तरफ जाने के लिए प्रयास करें, जल्दी करेंगे। नहीं तो आप इसको 7-7 दिन फिर ट्रैकेस्टमी करेंगे, फिर तो ये लग गया, ठीक है, फिर वो सारे वो झूठ जो थे ना वो सच होने वाले हैं। तो अर्ली एक्सट्यूबेशन की तरफ जाना है एंड रिड्यूस दी कार्बोहाइड्रेट। हम जब CO2 को कंट्रोल करते हैं, सारे तरीक़ों से कंट्रोल करने के बावजूद भी नहीं कंट्रोल होता, तो उसके खाने में क्या CO2 बन रहा, तो जितना भी ग्लूकोज की कंटेंट होगी, कार्बोहाइड्रेट होगा, वो कार्बन डाइऑक्साइड बढ़ाता है शरीर का। तो हम ग्लूकोज कंटेंट कम करते हैं तो स्पेसिफिक फीड्स आती हैं, हम बस इसका रेशियो चेंज कर देते हैं, फैट और उस पर ज़्यादा चले जाते हैं, इनटेक फैट और प्रोटीन पे रिलाई करते हैं रादर देन कार्बोहाइड्रेट इनटेक। ये सब चीज़ें रेगुलेट करते हैं हम फॉर वेंटिलेटेड पेशेंट्स। आई थिंक सो दिस बैटरी इज रनिंग लो, ओके, ख़त्म होने वाला है। मोर्टेलिटी एक आई थिंक लास्ट या प्रीवियस टू लास्ट उन्होंने बताया, ये अगर ICU में गया तो ये मोर्टेलिटी देखिए बढ़ती जा रही है। 5 साल में 76% चांस है ये मर जाएगा पेशेंट। अगर ये COPD का पेशेंट ICU में घुस गया तो 5 साल में 76% चांस है ये मर जाएगा। ओके, तो ये परसेंटेज है, एकदम प्रूवन लिटरेचर है, चेस्ट में पब्लिश्ड है ये। इंटरप्ले, एक चीज़ का ध्यान रखिएगा, COPD का पेशेंट कभी भी अकेली बीमारी के साथ नहीं आता। जो पेशेंट बार बार एग्जैजर्बेट हो रहा है वो इन सब बीमारियों के साथ में होगा। उसको हार्ट फेलियर भी हो सकता है, उसको AF एंड फ्लटर भी हो सकता है, उसको डायबिटीज़ भी हो सकती है, उसको पल्मोनरी हाइपरटेंशन भी हो जाएगा, ISD भी। तो केवल COPD को ट्रीट करके आप प्लीज़ कभी मत सोचिएगा कि आपका पेशेंट यहाँ से चलता जल्दी जाने वाला है। ये सारे फैक्टर्स हैं जिनको आपको देखने की ज़रूरत है, क्योंकि ये इंटर रिलेटेड है। HR माने हैज़ार्ड रेशियो कितना है, ये एरो देखिए दोनों तरफ बना हुआ है। COPD इन बीमारियों को ख़राब कर रहा है और उल्टा भी बना हुआ है। तो ये कैस्केड को ध्यान रखिए फॉर मैनेजमेंट। तो अगर मैंने COPD का तो सब सीख लिया, गोल्ड के हिसाब से कर लिया, उसके बाद भी कर लिया, लेकिन ये सारी बीमारियों को साथ में टैकल नहीं किया तो मेरा ट्रीटमेंट कंप्लीट नहीं है, ठीक है। तो ये स्पेसिफिक पल्मोनरी के लिए है क्योंकि वो उनका फील्ड है COPD, लेकिन ध्यान रखिए ये सब भी आपको आना है क्योंकि ये सब मुसीबत करेगा आपके पेशेंट के लिए। पिटफॉल्स जो अवॉइड करना है ACOPD के लिए स्टैंडर्ड है, सबको पता होना चाहिए। आई जस्ट एन्यूमरेट क्योंकि इंपॉर्टेंट है। हर यंग एडल्ट को जिसको ACOPD हो रहा है, बुरा COPD जैसे की तरह प्रेजेंट कर रहा है, उसको कॉमन कोल्ड या सिवियर कोल्ड की तरह मत माने। ये पहली बार आया है, अरे ये तो कफ एंड कोल्ड लग रहा है ना, ये तो इसको डिले कर दिया डायग्नोसिस पे, तो आपके पास पहली बार भी ऐसा पेशेंट आ सकता है, ठीक है। तो ये पिटफॉल है। लीविंग COPD पेशेंट्स तो आपके पास खूब सारे हैं OPD में, लेकिन उनकी फैमिलीज़ को नहीं मालूम ACOPD होगा तो क्या करना है, कैसे पता करना है, कहाँ पे जाना है, पेशेंट को भी नहीं मालूम ना उनकी फैमिलीज़ को, ये भी पिटफॉल है आपका। मिस जज इमिनेंट डेंजर्स ऑफ ACOPD, लाइक कि इसको हॉस्पिटल में जा रहा है, ये ICU में जाने वाला है, ये मृत्यु दर हो सकता है इसका, ये सब आपकी फैमिलीज़ को आपको प्रोग्नोस, ये मिस जजमेंट है। एज अ फिजिशियन आप मिस जज करते हो, अरे पहली बार आया ACOPD, भैया कुछ 6 महीने बाद इतनी बुरी हालत में आएगा अगर आपने ध्यान नहीं दिया अभी, ठीक है। तो यू हैव टू अंडरस्टैंड दैट। फॉरगेट दैट द कॉजेज ऑफ ACOPD केवल इन्फेक्शियस होते हैं। ACOPD केवल इन्फेक्शन के कारण नहीं होता है, बहुत सारे नॉन इन्फेक्शियस कॉजेज भी होते हैं जो एक्यूट एक्सैजर्बेशन ऑफ COPD। इसलिए हर चीज़ का रामबाण जैसे ACOPD में एंटीबायोटिक सबको दबा के दिया जाता है, वो सही नहीं है। इसलिए अब ईसनोफिल के क्राइटेरिया, एंटीबायोटिक किसको देना है किसको नहीं देना है ये आ गए, क्योंकि हम दबा के सबको लिख रहे हैं। एट्रीब्यूट उस पेशेंट को चेस्ट पेन हो रहा है, हमने उस चेस्ट पेन को ACOPD के साथ तो रिलेट कर दिया, लेकिन उसको तो ACS था वो ध्यान नहीं दिया, उसको निमोनिया था ध्यान नहीं दिया, उसको पल्मोनरी एम्बोलिज्म हो रहा है ध्यान नहीं दिया, न्यूमोथोरक्स हो रहा है। तो सारे ACOPD के चेस्ट पेन ACOPD के कारण नहीं है, वो ध्यान रखना है। अभी मैंने जो कैस्केड बताया था बीमारियों का, उन सबको यू हैव टू रिलेट टू देम, ओके। लास्ट, आपने रियलाइज नहीं किया कि ACOPD माइल्ड में भी हो सकता है. A mild COPD can also have an AECOPD. ओके, आप ये मत वेट करें कि मॉडरेट और सीवियर में ही आएगा. इट कैन अपीयर इवन इन द माइल्डेस्ट फॉर्म्स ऑफ COPD. फर्स्ट एपिसोड के साथ आ गया आपके पास में. सो दिस इज ऑल पॉसिबल. ये सब पिटफॉल्स हैं. एज अ फिजिशियन हम ये सब गलती करते हैं, मैं भी करता हूँ. आपने अपॉर्चुनिटी भूल गए कि शॉर्ट कोर्सेज ऑफ एंटीबायोटिक्स आर बेटर दैन 14-day कोर्स. 5 दिन की एंटीबायोटिक, केवल 5 days. ओके, 5 दिन का स्टीरॉयड, शॉर्टर कोर्स, लंबा स्टीरॉयड्स नहीं. चाहे आप मिथाइलपेडनिसोलोन यूज करें, चाहे कुछ करें, शॉर्टर थेरेपीज आर बेटर बिकॉज दीज पेशेंट्स विल कीप ऑन कमिंग टू यू. शॉर्टर कोर्सेज आर बेटर. ओके, ये लिटरेचर है, ये प्रूवन है. मिसिंग अपॉर्चुनिटीज, नॉन फार्माकोलॉजिकल इंटरवेंशंस के बारे में आपने पेशेंट को रियलाइज ही नहीं कराया कि सब कुछ ट्रीटमेंट नहीं है. इसके साथ में लाइफस्टाइल चेंजेस है, क्योंकि सिंड्रोम एक्स का COPD के साथ कनेक्शन है. तो लाइफस्टाइल मॉडिफिकेशंस हैं, नॉन फार्माकोलॉजिकल वैक्सीनेशंस हैं, न्यूमोकॉकल वैक्सीन, इन्फ्लुएंजा वैक्सीन, ये सब आपने एजुकेट करना. ये सारे पिटफॉल्स हैं. जब मेरे पास एज एन OPD ये पेशेंट आएगा, मैं मिस करूँगा. तो डोंट फॉरगेट दिस. और लास्ट, नॉट रिकॉग्नाइजिंग द इम्पॉर्टेंस ऑफ कोमोबिडिटीज़. 3 कोमोबिडिटीज़ को ज़रूर ध्यान रखें, GERD, OSA और एस्मा. ठीक है, ये तीनों को देखना है, क्योंकि पेशेंट GERD के होते हैं, आप उनको एस्मा मान के ट्रीट कर रहे हैं. आपने GERD टैकल नहीं किया, इनहेलर पे भी आ गया, ICS पे भी आ गया. OSA का पेशेंट है, मान के चल रहे हैं ये तो COPD है, आप COPD ट्रीट कर रहे हैं, OSA के लिए सर्जरी और चीज़ें या नेजल CPAP रात में वो नहीं किया. सो दीज आर इम्पॉर्टेंट डिफेक्ट्स जो पिटफॉल्स होते हैं. लास्ट में बस आप सबको थैंक यू कहूँगा फॉर द इन्वाइट. होपफुली द लेक्चर फिनिश्ड इन टाइम. इफ़ देर आर क्वेश्चंस, मैंने कंट्रोवर्शियल एरियाज नहीं डाले हैं, मैंने 4 पहले ही बताए कंट्रोवर्शियल्स. ठीक है, थैंक यू.
Sir, very wonderful presentation, sir, and I just feel honored that I am chairing my respected teacher, Dr. R.K. Singh sir. And sir, I think you have elaborated each and everything in acute exacerbation of COPD. Few things that I think audience should also want to know, that what will be the setting of various ventilator parameters in COPD versus ARDS, and why?
Look, ARDS means hypoxic respiratory failure. Okay, तो हाइपॉक्सिक रेस्पिरेटरी फेलियर मॉडरेट टू सीवियर ARDS में कभी भी NIV को प्रमोट नहीं किया जाता. माइल्ड में यू कैन स्टिल यूज NIV, लेकिन मॉडरेट टू सीवियर ARDS में कभी भी NIV के लिए रिकमेंडेशंस नहीं है. वहाँ पे इंट्यूबेशन और वही आता है. ठीक है, लेकिन जब ACOPD है तो मिनिमम सेटिंग्स जो हैं 10 से लेकर 15 IPAP और 5 से लेकर 8 के बीच में इनिशियल सेटिंग्स हैं. कभी भी NIV की सेटिंग्स को एकदम से ऊपर नहीं जाते हैं, क्योंकि अडेप्टेबिलिटी इश्यूज होते हैं. इट इज़ बेटर टू स्केल इट अप. तो 10-5 इज़ योर इनिशियल पॉइंट टू स्टार्ट विद. और एक और चीज़ ध्यान रखना चाहिए कि इसका दोनों को ऐड करके जो वैल्यू आता है, कभी भी 30 के ऊपर गया तो ये इंटूबेट वाला पेशेंट है. दोनों को वैल्यू ऐड कर दूँ तो 30 के ऊपर गया तो ये इंटूबेशन वाला पेशेंट है. स्टार्ट विद लो, मॉनिटर योर सैचुरेशन, सी योर फ्लोज, ensure that hydration is given through the circuit. ह्यूमिडिफिकेशन है, क्योंकि ये ड्राई एयर होती है एकदम, ये पूरा एयरवेज को क्लॉग करेगी, आपका ऑब्स्ट्रक्शन बढ़ाएगी. टर्बुलेंस मीन्स मोर एयरवे ऑब्स्ट्रक्शन. तो जो एयर अंदर जा रही है ड्राई, वो टर्बुलेंस क्रिएट करती है, इसलिए उसको ह्यूमिडिफाई करना है, नहीं तो ये प्रॉब्लम्स आपकी बढ़ेंगी. आपने लगा तो दिया बाईपैप, लेकिन ह्यूमिडिफिकेशन का ध्यान नहीं दिया, तो ये और एयरवे ऑब्स्ट्रक्शन क्रिएट करता है आपके लिए. तो जस्ट बी केयरफुल इन दैट एलिमेंट.
Sir, I am asking about the invasive mechanical
ठीक है,
ventilation
invasive
in COPD versus
ठीक है.
ARDS.
जब हम स्टार्ट करते हैं तो अगर मैं एडल्ट को कर रहा हूँ तो मैं मिनिमम 12 रखूँगा, क्योंकि 12 ट्यूबिंग्स का प्रेशर होता है. जब मैं इन्वेज करता हूँ तो मिनिमम जो एयरवे ट्यूब्स का जो प्रेशर्स को कम करने, यानी जो सर्किट होता है पूरा, वो मिनिमम 10-12 होता है. तो उसके बियॉन्ड मुझे जाना है, तो हमारी सेटिंग्स 15 हो सकती है, 15-5. ये हम यूजुअली वेंटिलेटेड वाले पेशेंट्स के लिए कर रहे हैं, इंटूबेटेड में. तो 15-5, देन 30 मिनट बाद गैस टू अंडरस्टैंड दिस पेशेंट, ABG, एंड देन वी कैन एस्केलेट और डीएस्केलेट बेस्ड ऑन दैट. तो वेंटिलेटर पे 15-5 से स्टार्ट करते हैं, क्योंकि पीप हमने कहा ज़्यादा पीप मुसीबत है, क्योंकि डायनेमिक हाइपर इन्फ्लेशन. तो 15-5
Sir, how to know patient develop R2P or how much
Okay,
R2P?
so the graph, one is that the graph will show you. तो जो लूप्स होते हैं, फ्लो वॉल्यूम लूप्स होते हैं, उनमें आप ट्रैक कर देते हो कि पीप की सेटिंग्स तो 5 पे, तो ग्राफ गिर रहा है 5 तक, सेकेंड 5 पे नहीं गिर रहा है, ये तो ऊपर रुक रहा है, तो 5 की सेटिंग्स पे नहीं है तो 8 पे रुक रहा है, तो 3 ऑटो पीप क्रिएट हो गया उसके ऊपर, 5 पहले का 3 और, तो 8 का ऑटो पीप है, तो मैं पीप की सेटिंग्स और कम कर दूंगा कि मैं 5 पे नहीं काम करता, लेट मी वर्क ऑन 2 ऑन दैट, क्योंकि 5 तो ऑलरेडी क्रिएटेड है. सो दिस इज हाउ, सो वो फ्लोज होते हैं, लूप्स होते हैं, वो दिखा देते हैं आपको कि कितना ऑटो पीप है. प्लस पेशेंट का बीपी ठीक था, सडनली उसका बीपी गिरने लग जाए, तो वो डायनेमिक हाइपर इन्फ्लेमेशन, इंट्राथोरेसिक प्रेशर बढ़ रहा है. तो दीज आर सिंपल क्लूज जो मुझे इसको करना है.
Are there any questions from audience?
ऑडियंस के लिए बहुत हैवी हो गया है ना.
Thank you very much, sir,
Thank you.
for your elaborate lecture.
Thank you, sir.
Thank you,
Thank you so much, sir. Wonderful.
Thank you, sir, for this wonderful session. Now, I would like to invite Professor Ved Prakash, sir, to come on stage and facilitate our speaker, Professor R.K. Singh, sir. I request Professor Ved Prakash, sir, to felicitate Professor R.K. Singh, sir. I request Dr. Rahul Chandola, sir, to felicitate Dr. Heather Abbas, sir. Dr. Avinash Agarwal, sir. Dr. Radhesham Gangwar, sir. Dr. Nikhil Gupta, sir. Dr. Nikhil Gupta, sir. Moving ahead with our last session, I would like to invite the chairpersons, Dr. D.K. Verma, sir, Senior Chest Physician, Civil Hospital, Lucknow. Dr. D.K. Verma, sir, Senior Chest Physician, Civil Hospital, Lucknow. Dr. Ram Narayan Rawat, Senior Chest Physician, Balrampur Hospital. Dr. Anand Gupta, sir, Senior Chest Physician, Balrampur Hospital.
Thank you, chairpersons. And very good afternoon to all you sitting. Here are some teachers, some senior colleagues. Professor Rajan Prasad is not here, he left. And my dear colleagues. So this is the last session. So I would like to thank the organizing committee to giving me the opportunity to speak on the plethysmography in obstructive airway disease. ये जो एरिया है प्लेथिज्मोग्राफी का, इसमें फिजिक्स इन्वॉल्व है काफ़ी. तो वैसे तो यहाँ पे मेडिकल के स्टूडेंट्स हैं, सब मेडिकोज हैं, और जो फिजिक्स के प्रिंसिपल्स हैं शायद आप लोग भी इतने समय से प्रैक्टिस में हैं, तो फिजिक्स वाला तो भूल ही गए होंगे. वैसे भी मेडिकल वालों की थोड़ी कमजोरी रहती थी फिजिक्स, लेकिन फिजिक्स में मैंने जो है टॉप किया था. हाँ, जब CPMT में सिलेक्शन हुआ था तो उल्टे थे मेरे नंबर. सबसे ज़्यादा फिजिक्स में थे, फिर केमिस्ट्री में थे, फिर बॉटनी और सबसे कम जूलॉजी में थे. तो मेडिकल में इसीलिए थोड़े कमज़ोर रह गए हम लोग. अब दोबारा फिजिक्स पढ़ाना इतने समय बाद आप लोग बैठे हैं, तो ये इसी तरह का है. इसको समझना समझाना, बॉयल्स लॉ, वॉल्यूम, प्रेशर्स, चेंजेस, इनके जो इक्वेशंस हैं. जैसे गंजों को कंघी बेचना हो, गंजे को कंघी बेचने का जॉब है एक तरह से ये समझाना. लेकिन मैं कोशिश करूँगा कि पूरी तरह से कि कुछ मैं आप हाँ कहीं ना कहीं कंघी कुछ को तो फंसी सकती है. ज़्यादातर लोग तो के तो ऊपर से ही जाएगा. सो माई ग्रेट टीचर, my mentor, Professor Rajan Prasad, is not here. I pay my gratitude to my mentor. So, body plethysmography. Plethysmos means enlargement, and graphin to write. So, plethysmography simply means to record the changes in volume. It means non-invasively lung volume outside thorax in a closed setup. It measures thoracic movements during breathing are recorded as pressure changes in the surrounding. So this is converted into changes in gas volume in the closed chamber, and this is the then indirectly used to measure volume inside the lungs. So, what are the indications of spirometry and body plethysmography? So, as you all know, the spirometry mobilizes और dynamic lung volumes को measure करता है, and body plethysmography, it measures non-moving or static lung volumes, and it also calculate the airway resistance. And basically the body plethysmography yields two values. One is functional residual capacity, FRC, and airway resistance. Out of this FRC you know it is ERB plus RB. So this is ERB. ARB is calculated by spirometry, and thus RB can be deduced, and similarly TLC can be deduced too. If we see this graphical presentation to understand the spirometry and body plethysmography, यहाँ पे हमारे सीनियर रेजिडेंट्स हैं जो ये कराते हैं सारे spirometry and plethysmography. So with this is the spirometry curve. With this we calculate or we have the value of FEV1, then FBC, and we derive FBC upon this FEV1 upon FBC, the ratio. So this is yielded from the spirometry. And this is, you all know, forced breathing maneuver and effort dependent process. In contrast, body plethysmography can detect obstruction by measuring airway resistance dependent of patient effort. ये इसके independent है. So we measure the TLC, total lung capacity. This flow time graph gives you with this spirometry, it gives you FEV1, FVC and the ratio, and it is obtained from the spirometry. However, it has some limitations. So this is the indications. Structural restrictions are true restrictions caused by limitation of lung movements, that is parenchymal disease like ILD, or limitation of thoracic movements like neuromuscular diseases. And it also, this flow volume loop obtained from spirometry shows that it can measure vital capacity and reserve volume. So this is vital capacity, then residual volume and total lung capacity, and hyperinflation and restrictions. So this flow volume loop obtained from spirometry shows the vital capacity and residual volume remains out of scope of this loop, and normal lung TLC constitutes of vital capacity plus reserve volume, residual volume. In hyperinflated lungs, TLC may be normal or increased, but RV will be increased considering higher RV upon TLC ratio. So this restriction, this restricted lung TLC will be reduced, but RV may be in restricted lung TLC will be reduced, but RV may be proportionately normal and reduced or increased depending on the pathology. So I think you all understand it now. And the displaced volumes, how to measure or perform body plethysmography. So displaced volume measurement is done during the plethysmography in the body box. Patient sits in airtight cabin, breathing air in and out from outside the box by a mouthpiece. So this is the mouthpiece. Mouthpiece has a pressure sensor that simultaneously measures mouth pressure and airflow. A second pressure sensor registers pressure changes in the cabin, and since the body box is closed and doesn't change shape, the volume and pressure in the box changes proportionately with chest movements, and related as the Boyle's law, volume multiplied by the pressure is constant, or V1 into P1 equal to V2 into P2. That is the Boyle's law. How the loop of body plethysmography
This is the physics to measure and calculate the volumes and pressure changes like V1. V1 is known volume of gas in the cabin before inspiration. V2 is volume of gas in the cabin after inspiration. V2 can be calculated from Boyle's equation. V2 minus V1 is delta V. That is the change in thoracic volume. Since delta V is almost equal to tidal volume when patient freely breathing outside air through mouthpiece, when test starts at close of shutter, discussed, this is delta V and called displaced volume or shift volume. Delta V corresponds to lung motion requires to after and the lung volume just enough to develop a negative pressure in alveoli lead to inspiration. So this is some critical physics and how the loop of body plethysmography look like. This is during inspiration the displaced volume of air and airflow rises initially with increased volumes. So in this graph the loop has been made slightly slanted and oblique with showing both limbs just for this is for audience purpose. Typically a normal individual loop is a flat straight vertical line. So this loop visualizes the work of breathing, that is it denotes which change in volume produce a specific airflow. In healthy individuals, loop is an almost straight line and the gradient, that is delta V upon F, that is SRO, specific airway resistance. That is the bronchial airway resistance need to be overcome to generate a specific flow. So detailed equation regarding the relation of airway and specific airway resistance is beyond the scope of the talk. Lung volume measurements. So this is assumption of the equation alveolar and mouth pressure after closing of shutter would only hold true in absence of significant airway obstruction, severe bronchospasm. If there is severe obstruction, pressure at alveoli and mouth will be different and the system will miscalculate TG volume and calculated thereby can be higher than that is really is. So the lung volumes, that is the occlusion pressure, there are correction equations available to calculate corrected FRC pleth, but we will not discuss it here. Overall, it only makes a difference of about 5% of the calculated volume at most. So this is the some error in the calculation. And how the normal graph look like? So normal subjects manifest a steeper linear loop during tidal breathing without hysteresis, that is no openness. This is the hysteresis. This yes, इसको करो भाई, someone please help को प्रेजेंटर व्यू पर लगाना जरा. So this is the openness, this is hysteresis. When there is a small airway resistance or because of diseases, so this openness increases. So this is hysteresis. Flattening increased openness, localized resistance. During
the fifth, during painting, the upper and lower extremities of loop become curvilinear and S-shaped. Now we come to the utility of body plethysmography and in clinical practice. So restriction can be suspected by spirometry when FRC is reduced, that is less than 5th percentile, and FEV1 upon APC is normal or elevated. However, it can be confirmed only when TLC is reduced, that is less than 5th percentile, or Z score is less than minus 1.65. So 5th percentile means less than lower limit of normal and is indicated by a Z score of less than 1.65. Body plethysmography, the utility in plethysmography obstruction is demonstrated by elevated airway resistance and specific airway resistance. Then TLC and RV may be normal or elevated. In case of hyperinflation, in case of severe defect, pressure changes are not transmitted to mouth as such, so that may be misdiagnosed as obstruction. How the large airway obstruction look like? So this is there is uniformity, increased airway resistance, and not localized. So there is a later hysteresis or openness, linear specific airway resistance loop, and that is tilted clockwise, manifests a slope less steep that normally reflects the increased airway resistance. And this is the small airway. How the small airway obstruction look like? In patients with non-homogeneous airway obstruction, there is openness, hysteresis in the loop. This is the hysteresis. The hysteresis, this is like a golf stick. So it denotes the larger changes in the shift volume that occurs at mid expiration without comparable increase in the flow. So now to revise, these are the kind of loops. So A is, A वाला बताइए, आप लोग सब बैठे हैं करते हैं, ये नॉर्मल कर्व है. So this is normal plethysmography curve, and this B, there is little openness throughout, so this is localized obstruction. And this hysteresis है, यहाँ पे hysteresis है और appearance कैसा है, golf stick वाला है. तो ये कौन सा हुआ, स्मॉल एयरवे ऑब्स्ट्रक्शन. ये स्मॉल एयरवे ऑब्स्ट्रक्शन का है, या फिर हाइपर इन्फ्लेशन में भी ऐसा मिल सकता है. और ये डी, इसमें आप देख रहे हैं ओपननेस है सेंटर में भी और हिस्टेरेसिस भी है. ये कैसा है, दिस इज लाइकली अपर एयरवे ऑब्स्ट्रक्शन. सो these are the kind of graphs. This is the body plethysmography. This is body box. In I think our department the same. So rationale. What is the rationale? Spirometry measures the dynamic lung volumes, gives us information regarding airway obstruction, and indicates towards restrictive pathology. While static lung volumes are required to confidently diagnose restrictive pathology, and simple spirometry doesn't measure airway resistance, hyperinflation, and residual volumes. So the importance
of lung volume is to confirm restrictive lung disease and to differentiate into pulmonary or extrapulmonary, to confirm and quantify hyperinflation or air trapping, distinguishing mixed disorder, and the role of airway conductance. So, airway specific, it is great sensitivity of obstruction in the central part of the bronchial tree, that is the specific conductance of airway. SGAW is specific conductance of airway, and it is opposite of resistance. Less sensitive to obstruction of peripheral airways, and this specific conductance of airway is more sensitive to bronchodilator response than spirometry. So, the improvement of specific conductance of airway by 50% or more indicates reversibility with certainty. So, it can be used to assess bronchoconstriction in bronchial challenge testing. There is a 40 to 50% drop in the conductance. So, what are the normal values? No specific reference equation for Indian population has been studied or derived. Most studies report their observation range. Few references equation are there for Western population. Specific airway resistance and conductance depends upon height and age. So, these are the normal values. How to interpret? This is important. How to interpret? So, if TLC is less than 5th percentile, if yes, then it is restriction, and if TLC is more than 95th percentile, no, then it is simply the restriction. What kind of patient? Like in ILD. And if TLC more than 95th percentile, then it is FEV1 upon FBC is less than 5th percentile. If yes, then this is mixed disorder. Mixed disorders like restriction with obstruction or hyperinflation, like post-TB lung damage and compensatory emphysema. If this 5th percentile FEV1 upon FBC is less than 5th percentile, if no, then this is complex restriction like in neuromuscular diseases, kyphoscoliosis, pulmonary agenesis, post-TB destroyed lung, and compensatory emphysema. If the 5th percentile TLC is less than 5th percentile, these were the disorders. If not less than 5th percentile, TLC is more than 95th percentile. If no, then it means TLC is between 5th and 95th percentile, that is normal. If FRC upon TLC or RB upon TLC is more than 95th percentile, then it is hyperinflation. If no, then it is normal lungs. If TLC is more than 95th percentile, then it is possible hyperinflation. Then if RB upon TLC is more than 95th percentile, this is hyperinflation. So, specific airway resistance, and it adds to the information if needed. So, this is these are some cases, interesting cases. This is case 1, a 56-year-old male, chronic smoker, complaining of dyspnea and cough for 2 years, prone to cough, and his cough is minimally productive. Past medical history is nothing significant. So, this is the RB. This is the RB, and TLC is 6.34, in pre predicted, and this is the pre measured, and this is the percentage. And RB and TLC is 38.14, and this is high, so 70.50, and ratio is 184. So what is this? This is obstructive pattern. So bronchodilator का जो response होगा इसमें कैसा होगा? Absent होगा. So this is obstructive pattern, bronchodilator responsiveness absent. This is another case scenario. A 26-year-old male, non-smoker, complaining about dyspnea for last 2 years, and on and off chest tightness, seasonal variation of symptoms persistent, and history of allergic rhinitis. And this is these are the values. So what is this case scenario? And having dyspnea, spirometry is normal, and this RB upon TLC is increased, so suggestive of normal या hyperinflation. चलो hyperinflation भी हो सकता है ये, हैं? So this is bronchial asthma, spirometry normal, body plus shows raised RB upon TLC. So this is this is another case. We have with us 23 years male with left upper lobe post TB aspergilloma, as you can very well appreciate this aspergilloma here, and the spirometry shows FEV1 upon FVC, that is FEV1 upon FVC is more than 70 of predicted, and FEV1 is 49, FVC is 60. That is the suggestion of the spirometry. तो इसमें क्या लग रहा है? प्रिज्म हो सकता है, ऑब्स्ट्रक्शन हो सकता है, हैं? अब जेड स्कोर क्या बता रहा है आप देखो, एक मिनट, जेड स्कोर के हिसाब से क्या आ रहा है? ऑब्स्ट्रक्शन आ रहा है. तो इसके इम्प्लीकेशन क्या हुए? सो रेशियो प्रिजर्व्ड है, इम्पेयर्ड स्पायरोमेट्री है, फिर हम लोगों ने इसकी बॉडी प्लेसिस्मोग्राफी की. सेकंड चार्ट में ये बॉडी बॉक्स है और द TLC इज लेस देन 5th percentile and Z score is 5.3. So this is severe reduction in TLC. RB upon TLC is more than 95th percentile. Z score is more than 8.8. So this is severely high. FEV1 upon FVC is less than 5th percentile. So suggestive of what? Mixed. Mixed disorder है. Hyperinflation है. Both lung volume loss है, and hyperinflation है. So this is mixed disorder. Okay, so this is a case, another case. 30-year-old male with previously treated pyothorax presenting with chest pain. X-ray shows pleural collection, organized USG and pleural thickening. So this is the X-ray showing pleural thickening. So this is the FEV1%
This is 88.12 FEV1 upon IPC. FEV1 is 63, FVC 67. तो क्या हुआ ये? Restriction. Restriction आ रहा है ना इसमें. Now we come to body box. अब body box को देखिए. Body box में TLC is more than 5th percentile, but less than 95th percentile, within normal limit. RB minus Z score is 1.2, and RB upon TLC 2.8 upon 4.6 equal to less than 50%. So that is less than 5th percentile. Acceptable normal. This is. So this signifies normal lung function. Also note that specific airway resistance and airway resistance are not elevated. So what does this tells us? With detailed functional evaluation by body plethysmography and single breath diffusion studies, patient can be closely followed. So this is certain cases like post-TB sequel, patient fall under PRISM category, and other scenarios like patient with borderline spirometry. These patients remained under or over-diagnosed and under or over-treated. So their functional assessment are not routinely done and is usually limited to spirometry availability issues are also there, not available at all the centers, and body plethysmography can be well used in these cases to define the interpretation, and with detailed functional evaluation by body plethysmography and single breath diffusion studies, patient can be rightly diagnosed, rightly treated, and can be closely followed. So concluding, in body plethysmography is an important tool for thorough functional and physiological assessment in pulmonary patients with compromised lungs, and it provides greater insight into the type of disability and impairment. It can guide treatment and framing management plan for pulmonary patients. Availability, training, and cost of procurement remains an issue in smaller settings. So this is the conclusion. Thank you. Thank you for patient listening.
हमने ईमानदारी से पहली बार प्लेथिस्मोग्राफी पढ़ी है आज आपसे और बस ग्राफ समझ में आया, जो अगर लूप कोई दिखा देगा तो शायद मैं पकड़ लूँगा, बाकी तो काफ़ी कुछ वास्तव में ऊपर गया, लेकिन ये कि अब स्टिमुलेशन मिला है तो खुद से भी पढ़ूँगा और फर्स्ट टीचर रहेंगे आप प्लेथिस्मोग्राफी के मेरे। थैंक यू। किसी को कुछ क्वेश्चन? जो मैंने कहा था कि गंजे लोगों को कंघी बेचने वाला ही जॉब है ये। हाँ। लेकिन कोशिश की है, मुझे लगता है कि 2-3 बार जब ये आप अटेंड करेंगे जी बिल्कुल, तो फिर ये रिटेन होना शुरू होगा। बिल्कुल बिल्कुल। तो आज ये थोड़ा ओरिएंटेशन हो गया। मैं स्पेलिंग के अलावा आज तक प्लेथिस्मोग्राफी में कुछ पढ़ा नहीं था इसकी। तो ये फिजिक्स के आदमी से पढ़ना ही ठीक है जी। बिल्कुल बिल्कुल। मेरी थोड़ा ठीक थी तो मैं थोड़ा समझा इसको। नहीं ठीक है, बहुत बढ़िया जी। शायद मैं कभी पढ़ता नहीं अगर आज ये लेक्चर नहीं होता। एनी अदर क्वेश्चंस? थैंक यू। Now we close the session. Thank you, Dr. Ved Prakash, for enlightening us. Thank you. Thank you. Thank you, sir. Thank you.
Thank you, sir, for this wonderful session. Now, may I request our chairpersons to come on the stage and felicitate our speaker, Professor Ved Prakash, sir. Now I request Professor Ved Prakash sir to felicitate our chairpersons, Dr. D.K. Verma sir. Dr. Ram Narayan Rawat sir. Dr. Anand Gupta sir. Well, there is a saying, the end of one chapter is just the beginning of another, so keep reading. The best part is always yet to come. With this, I would like to invite Dr. Sachin sir to come on the stage and give vote of thanks.
Thank you so much. As we all know that our Department of Pulmonary and Critical Care Medicine organizes COPD update every year on the occasion of World COPD Day. This program is used to be organized to aware the general public, as well as we organizes the academic fees to aware the clinician about the different aspects of COPD diagnosis and management. This year also we have organized such a successful event where many participants has been attended the program from the different part of Lucknow. This program has come to an ending. On the behalf of organizing committee, I would like to thank Professor Sonia Nityanan ma'am, Honorable Vice Chancellor KGMU, the guest of honors, Professor Amita Jain ma'am, Professor Rajendra Prasad sir, Rahul Chandola sir, who has managed their time for making this event successful. I would like to thank all the speakers and chairperson for making the academic sessions successful. Those have delivered the words of wisdom to this session and added the knowledge sharing and experience to the participants. I would like to thank all the delegates, senior residents, junior residents, all the nursing staffs, office staffs, who has been working tirelessly to make this event a grand success. I would like to thank Lupin Company and their representatives for their sponsorship and for hard work for making this event successful. I would like to thank Kapoor Studio for managing this event nicely. I would like to congratulate and thank you, respected our head of department, Professor Ved Prakash sir, for organizing this event. Under the guidance of his words of wisdom, we hope that we will expand the department to such an extent that the Department of Pulmonary and Critical Care Medicine will be becoming the gold standard in country as well as abroad. Thank you so much.